I love the energy. Let's keep this up for the next 2 days. My name is Dr. Karen Tabb Dina. I'm one of the leads, along with Brandon Moline, David Huang, and Kelli Ryckman, on the IDEA Coalition and this PCORI-funded symposium that we're all attending today. In the next 2 days, we're going to cover everything maternal mental health. Well, we're going to get as close as we can. We're not covering everything. But we are going to highlight the role of patient involvement in research and stakeholder involvement in research, highlight several of our projects that are ongoing, and end with a workshop. So hopefully this is the start or a continuation of a movement of changing the way that we think about solutions to problems and improving clinical solutions through research findings. I just want to extend a welcome on behalf of our coalition to all of you. We're excited that you're here, and I will turn it over to my boss, Dean Steve Anderson from Social Work. Thanks.
Using the word boss with me is used very loosely, but I do want to thank Karen at any rate, and I want to welcome everyone here on behalf of the School of Social Work. There'll be other welcomers as well. We're very excited about this work, and we're happy to be a small supporter of it. We're very happy that PCORI's played such an active role on this. For social work, this kind of engagement is central to us. It's what we focus on in terms of research. We try and be engaged, and I know Karen and her colleagues really exemplify that. So I've gotten to know a little bit about the topic. It's not my field, but because I have to read Karen's work for one reason or another, I should say I get to read it, but I've educated myself slowly over time, and it really has helped me become familiar both with the extent of the problem and also the level of engagement that working with their colleagues she's brought in terms of bringing people who really have personal experiences into the whole research and engagement process. And so for us, this is very exciting. It's something that we strive for, and I'm very happy that you could all come. She told me there's people here from 7 states, and I know there's a lot of community members here as well. So this is what we strive for, and I really hope you have a great conference while you're here. So welcome.
Hi, welcome. I am Julie Pride. I'm the administrator of Champaign-Urbana Public Health District, and that's where Brandon Moline comes from. We've been working on perinatal depression screening for over a decade now. There are limited options out there for people that are at risk, and there are very limited treatment options. So we are excited to be participating in this patient-centered research. Champaign-Urbana Public Health District is unique as far as health departments go because we're a district, and that allows us to be super flexible. We can participate in research more often than other health departments. We have a 3-person board, so we can change like that when something comes up and we need to switch directions. We do everything with a leadership team rather than me making all the decisions, because you don't want that. And so ideas always come from clients or from staff doing frontline work, and that's why we get such amazing programs and opportunities as this. And being in the community with this, the University of Illinois has opened up a lot of opportunities and partnerships. So we're really, really happy to be a part of this, and we are excited to have all of you here, and I just want to welcome you all to Champaign-Urbana, and if you need any assistance knowing what restaurants are safe or where you may need to get treated for chlamydia, just ask Brandon. Thank you, welcome, have a good time.
Good afternoon, everyone. My name is Huang, and I'm interim head of education policy, organization, and leadership here at the University of Illinois. And I wanted to personally welcome all of you to this national symposium that's very important and certainly where education is also center and at the core of how we're thinking and learning about perinatal research, but also how does this incorporate the various ecosystems, as I would think about it, in terms of the life of the child, let's say, but also how is that incorporated within the natural environment, the social, political, historical contexts of how we are all embedded within our communities, and certainly within education systems. And of course, I define that in a very broad sense. So I want to thank you and welcome you for coming to this very important event, and to let you know the support that you have in terms of what education is and how it plays a part in the whole various systems of thinking about mental health and wellness. Because as we know too, in a lot of the research that's out there that we know on P-12 education systems, as well as now within higher education, the role of mental health, especially among students, is very important as we go through this process. But as we also know now, in terms, and increasingly, we have known this over the decades, but what does this mean in terms of early childhood health and wellness? But now, with this new research and initiative and the ways in which that you are incorporating and engaging with patients in the local community, what does this mean at the perinatal stage? So I'm so encouraged to know and to see that this is happening, as I mentioned again, with this ecosystemic perspective of wellness and the role that mental health and wellness comes into play. And the other element that I find so encouraging about this area and collaboration in particular is the way that it brings in different constituents, not only at the university level and with faculty from my department in particular, Dr. David Huang, who's instrumental in this research symposium, but also how it engages with our local communities and our organizations. So how we are working together and systemically to work through the larger, broader social challenges that we face, but also seeing how these challenges are opportunities. And I appreciate each and every one of your efforts as a participant or as a presenter, but also in ways that we move forward together to really address some of these very important topics and issues that are at the heart of our local, our national, our global communities. So thank you again for your participation and your presence, and I hope you get so much out of this, because I may actually be asking questions to a number of you. All right, thank you.
Our first speaker is Leah Hotchkiss. Oops, you got it. I should not touch technology. Is Leah Hotchkiss from Pecori. She came to us from DC, and we're just so happy that she made it in despite the weather. So we'll have her slides up. Pay attention and take notes, everyone, especially our board.
We'll share the slides.
The first one.
Well, thank you so much for having me. As Karen said, I'm Leah Hotchkiss, and I direct the Engagement Award programs at Pecori. Pecori is the Patient-Centered Outcomes Research Institute. We just shortened it to Pecori. I'm going to tell you a little bit about our organization and the type of work that we fund, and then I'm going to talk a little bit about future funding opportunities that we have, and then open it up for questions. And I'll share my slides so you don't have to take notes. So what is Pecori? Who are we? What do we do? We are, as I said, the Patient-Centered Outcomes Research Institute, and we were actually established back in 2010. We were authorized by Congress as part of the Affordable Care Act, and we're governed by a 21-member board that represents stakeholders from across the entire healthcare system. We fund comparative clinical effectiveness research, which I will tell you about, but the important part here is that it's guided and driven by what's important to patients, and we really focus on funding research that we think can be actually applied and be used to help make decisions about healthcare, policy, and practice. So CER, we often refer to it as CER. It's a type of research for those of you who have not heard of this before. And the idea here is that it generates and synthesizes evidence that compares things against each other. So we're looking at 2 proven interventions, 2 proven programs, 2 proven ways to diagnose things against each other in trials. And we really make sure that the studies that we fund measure benefits and harms that really matter to people, so the outcomes that are part of the studies are really important. And we also take a look at subgroups. So the research that we fund looks at, what's the effect in women and what's the effect in different populations. And the idea here again is that we're helping consumers, clinicians, policymakers all have the information that they need to help inform their decisions. So we also refer to patient-centered outcomes research as PCOR. So this is a relatively new term, and what this means is that it's comparative effectiveness research that's guided by patients, and it really, as I said, takes into consideration what patients need, what they care about, what their preferences are, what's important to them, and we study what works best for whom under certain conditions. So the research that we fund is guided by our 5 national priorities. These were established with our board. And so we're looking at research that addresses how to improve healthcare systems, different ways to communicate and disseminate research, how to address disparities, and different ways to assess, prevent, diagnose, and treat diseases. And our funding opportunities are typically arranged around these different priorities. And we have a pretty strict merit review process, pretty rigorous merit review process. What I think is unique about the research that PCORI funds is that built into our merit review criteria are number 5 and number 6. So is the research patient-centered? Does it actually focus on studying something that has the potential to improve patients' outcomes? Does it have a patient-centered design? So as the investigators have planned out their study, are they actually talking to people? Do they have them at the table? Are they helping identify the questions, design the trials, look at the outcomes? Are they going to be involved in recruitment and retention efforts? Are they going to be at the table when the results come in and think about how to get them back to the community? So we really put that emphasis there so that the investigators who apply for our funding have to make it clear how they're involving patients and having them at the table as partners. And that's the last comment here, that we really view patients as critical to the work that we fund, and so we are looking for evidence that the project team is going to include the patients at the table as partners, not just study subjects. The research that we fund also really spans the spectrum, but we're really interested in finding research that looks at conditions that place a heavy burden on patients. So the work that you all are interested in doing, maternal child health issues, incredibly important. We're looking at research that takes into account those who have multiple conditions or chronic conditions. We have a whole special portfolio of funding for rare diseases. And then, as I said, we really care about how these different diseases and how these different treatments affect different subpopulations. So how much have we funded? Who are we funding? What does it look like? Since we were created back in 2010, we've awarded more than $2.4 billion. So we've been very, very busy over the last 9 years reviewing and selecting those studies that we feel have the greatest importance. This means that we have over 1,400 projects that we've funded. 600 of those are research studies. The rest fit into the engagement domain where I focus. And we have been able to award projects across the entire country. So this is really exciting for us. I don't know what's wrong with North Dakota, but if anyone has any leads in North Dakota, please let us know. I feel like we need to do an engagement outreach event or something to encourage them to apply so we can just shade out this map. A little bit more detail about our portfolio. As I said, we're looking at issues that are prevalent and affect a lot of people. So our mental health, behavioral health category is really, really prevalent. Cancer, after that, has a huge burden on the community. Neurological diseases, cardiovascular, et cetera. And then when I talk about studying different subgroups and priority populations, a huge portion of our studies here, I think over 300, are focusing on looking at racial and ethnic minorities, followed by those with low socioeconomic status, women, older adults, etc. So I pulled out a few examples of the research that we're funding at PCORI that might be relevant to you all, and I don't want to steal Dr. Tandon's project's thunder. I know you guys are here to talk about your work, but I pull it out because it's a really important study, and we're really proud to be able to fund this. And I know that there was it was picked up by the New York Times, so we're keeping a close eye on this one. But the idea here is to evaluate the effectiveness of their Mothers and Babies program, and you'll hear more about that this afternoon. Another study that we've been funding is taking a look at peer support after infants are in the NICU, and addressing parents' mental health outcomes. So they're looking at a program, the delivery of a program, and the effect on the parents' health as well as the newborn's outcomes. And then there's another study that I pulled out here. This one's been completed. There's some information about this study on our website from Dr. Lee over at Kaiser. And again, they were also looking at the effects of maternal depression, the treatment for depression, and on the impact on preterm birth and low gestational birth weight. This is just a tiny bit of our portfolio, but it was sort of a teaser to encourage you to go to our website to take a look at more of the research that we have in progress. We do post our abstracts and interim study results and lots more great pieces up on our website. So go there for lots of great findings. So engagement, this is really the heart of patient-centered outcomes research, the idea that patients are engaged as partners throughout the entire study process. And this is really where I focus. So the engagement awards that we fund are intended to support events just like this and projects just like this, where it's encouraging and building the capacity and the networks and just this interest and engagement in research. So as I said, what do we mean by engagement in research? It means that you're involved from the beginning to the end, all the way through getting the results out there. Our thought is that if that happens, that research is going to be more relevant. It's actually going to be, there's the likelihood of actually being used is so much better, and that the work will be more meaningful, relevant, and trustworthy. And here's just a diagram that we've put together. I think it's important to point out that we require anybody that we fund to demonstrate engagement in research, but we at PCORI also have many, many stakeholder engagement opportunities. We involve different advisory panels, different community groups, helping us to really identify what our research priorities should be, helping us to review our applications, to peer review the results that come in, and also we're now really focusing on disseminating and implementing the findings that we've been supporting the development of over the past few years. So I think the point here is that we walk the walk, we talk the talk. It's important to us just as it is important to anybody that we provide funding to. And so from my world, the engagement awards that I fund, they're typically up to 2-year projects, and their budgets are much smaller than a multi-million-dollar trial. We're funding projects for up to $250,000, but we've learned that groups can do a lot with $250,000, and it's been really, really professionally and personally rewarding to see a lot of these groups start with an idea and be able to turn it into a full-blown program with interest from many different stakeholders, university, community, the government stakeholders, et cetera. And so here's a few projects in our portfolio. We have almost 400 awards that we've made since we started the program 5 years ago. But here's just a handful, again, just a teaser to you all that there's a lot more information on our website, but here are some projects that I thought would be relevant to you all in the room. And the first one's actually happening in Rochester. I'm not sure if you guys know this group, but they're just getting started, so probably a great group to connect with if you aren't already. And then you'll also see we're focusing on really different topics here. I mean, we're looking at creating a community collaboration to address health equity with a women's network in Kansas. So it's a rural community that's trying to engage many different folks across their networks to address issues that are important to women. We've got a really important study that has been only awarded in 2018, but they've created a wonderful website, and they're creating resources and tools and lots of information for mothers with mental illness who are using opioids. So sort of a taboo topic, but incredibly relevant to what we're facing today, and they've got a wonderful website. So if you go to our site and you learn more about the project, you can get the link to that and check out what they've been doing in their community. Another one here, looking at developing a maternal child health network in San Francisco County. So this one is more urban-based, and they're looking at how to address maternal depression in San Francisco, and it's almost completed, and they've got some great resources that, again, we put on our website as a result. So my goal is, I think, to go back and talk with our communications teams about how we can better package all of the support that we're doing in this area so that we can better tell our story about how PCORI is helping to advance maternal child health issues, specifically mental health of pregnant women. So I'll keep you updated if they can put together a nice piece on that. But I think there's a lot to tell, and I'm tempting here to start to tell that story. So opportunities to engage with PCORI. As I said, we have our Engagement Award program. It's the funding opportunity that I oversee. We have something called our Ambassador program. This is an opportunity for individuals or organizations who want to get involved in PCORI. They want to learn more. They want to be notified about different opportunities to participate in meetings, to provide their voice to different opportunities. And it's a volunteer program. It's really just champions for PCORI, and we have folks across the country who are out there spreading the good word about the work that we do. So if you're interested, there's an application online and some training materials for those who want to become ambassadors. We also have opportunities for folks who want to be part of merit review, so to come together with the researchers and the other folks that we have at the table reviewing applications, so to participate in a merit review to select those projects that we fund. Peer review, so when the results come in, we've got peer review panels that include patients and other stakeholders providing comments on the draft findings. And then we have many meetings and events that happen throughout the year that are all posted on our website. We have a bunch of great resources up there, so if anyone is doing engagement and you're looking for some tools or some how-tos or some webinars about how to do engagement well, or some of the challenges that some folks have faced and how they've overcome them, we've got a lot on our site. And then finally, we have a really great option on our website now where if you see a study that you're interested in, you can click on a Keep Me Up to Date button, and you'll get reminders about when that project is nearing completion, so you can be sure to be up to date on our research. I do put out there the plug for the program that I run here. I apologize, it should be 2019, not 2018. But the idea here is that we have a funding opportunity that's posted up there now. We accept letters of intent for folks who have ideas, who want to address one of these different areas. And then we also have funding for conferences and meetings, so a little bit more narrow in scope and doesn't have to be 2 years. If you've got an event that has a patient-centered focus to it, we have funding for that as well. And then finally, PCORI hosts an annual meeting every year. This year it's going to be September 18th through 20th in Washington, D.C. It is free. It's open to the public. You just need to register and come to D.C. But for anybody who has the ability to come or interest to come, it's a wonderful opportunity to hear much more about our portfolios of work from those who are doing the work, and to network with each other who are all interested in engaged research. So our contact information is here, and I want to thank you. Again, thank you for this important work. We are really proud to be able to fund this with our PCORI. You're taking my picture, aren't you? It's hard to talk with someone taking your picture right there. No, but thank you. Truly, this is really important work, and I can tell you it is incredibly competitive to receive an engagement award. I don't know if you knew that, but I think the cycle that you guys applied, we had 150 letters of intent, or 150 people with ideas, and we funded maybe 30 of them. So this was really, we felt, an important project that continued the work that you started with your pipeline to proposal program work that I know some of you were involved with. So thank you for keeping those partnerships alive and going, for applying for this opportunity, and for spending the next 2 days keeping the momentum going. So thank you. I will take questions if you want. I'll be around all afternoon.
Do you have any advice for folks to get started? Because I know tomorrow we're going to
Yeah.
speak a lot about that.
Yeah, yeah.
What we think is important to get started.
To get started, if you are just starting with engaged research and you want to learn more,
So
or
like we have researchers in
Yeah.
the room, but we also have a lot of stakeholders and patients in the
yeah,
room. So
yeah.
what are those known strategies Corey suggested
Yeah.
for getting started and building
Yeah.
momentum around the topic?
I think it's not just building momentum, but it's building the partnerships and the trust and the relationships. And I can tell you from doing this work for 5 years, it takes time and it takes real, true passion and sincere effort. I think we see opportunities, we've seen in the past where, you've got researchers who will come into the community and say, yeah, we want to do this project and we need 3 people to be our partners. But to us, that's not true, meaningful engagement. So I think the idea is to take the time up front to really get to know each other, figure out where you have shared priorities, and take that time to take off your researcher hat and take off your doctor hat and just to get to know each other and see if there's a good partnership there that can be turned into something and be sustained over time and eventually turn into hopefully a blossoming research idea, research project. But yeah, just jumping in without doing that upfront work, I think we can sort of see through that when they do the reviews and they start to think about it. And I know it takes money, and that's why we have our engagement award program, because without having sort of that funding to be able to pay for the convening and to pay for childcare when you've got to come to a meeting like this, or to have space to do it, and to have the funding for the conference line or food so that you have something to share with each other, that sort of funding isn't typical. And so I think that's why there's such an interest in the type of projects that we provide funding support for, because nothing is free and people's time isn't free. And so we want to be able to provide those small funding opportunities to allow those relationships to happen and blossom.
So I'm wondering about what you guys have learned in terms of how communities work together to solve complex health problems. So the idea in a couple projects I work on, you see, primary care people, mental health people. And so I'm kind of curious of what the research has shown or demonstrating about what makes those things work or don't work, or maybe everything is idiosyncratic. It's unique to settings. But I guess, is there anything you guys,
Yeah.
sort of service integration, service utilization, how that works, I guess, since this is patient engagement from the patient's perspective?
Yeah, no, that's great. And you can appreciate that we have an entire group at PCORI dedicated to evaluating the impact of engagement and the effectiveness of engagement and what works and what doesn't work. And we have a lot of anecdotal information. They're trying to do a better job now at really capturing something more systematic. And in the past, I think we tend to go to the researchers and say, hey, tell us why your partnership worked, but we haven't done such a great job at going to the patients themselves or to the community themselves and say, hey, from your perspective, what made that relationship happen, what worked well? So I'm not sure if I have any specific tips other than to say, we're trying to learn, and I think the more that you can share with us from your perspective what works and what doesn't work well, that we can then communicate back to the research community is very helpful. I also think that we're in a really interesting point with PCORI right now, where we've been funding this type of research for, probably, it's not quite 9 years, probably 7 years now. And we have some results now of our studies. And so we're really thinking about, okay, so how do we work with these communities to then disseminate and then implement the research findings? And that's an area where we're really moving into now. So thinking about, okay, say you guys continue on and you identify, a priority topic that you all want to work around, and you go on and you apply for and receive funding for a large trial that looks at, comparing different interventions for how to improve maternal mental health. Okay, then what? How do you then take what you've learned, share it back, and actually make changes to reflect what you all have studied and learned? And that to us is an area where we're focusing a lot on. We're funding a lot right now about that implementation work, and we really hope to be able to let you know what works and what doesn't work. But share with us, and we can let folks know.
Can I ask you a
Sure.
I'm wondering about the notion or how it fits between, because you guys do sort of comparative effectiveness.
Yeah.
So I'm curious about how that sort of fits in with sort of the new discussion today about precision things.
Yeah.
Precision medicine.
Yeah.
Precision whatever. I even heard it used on
Yeah, no, I would.
called precision business.
Yeah.
I'm like, oh, this is interesting. I've never heard of it.
Yeah, and I think that you probably picked that up when we talk about at PCORI, the right intervention for the right person at the right time, given their individual circumstances. So, an example, right? I've been diagnosed with depression. I'm going to be given an antidepressant, but what matters to me in terms of outcomes? So maybe I'm more concerned about my nausea, or I'm more concerned about my sleeping or my sexual function, and so I think. The work that we fund tries to parse out the different outcomes for the different interventions that are being studied so that you can be fully informed about what works best for whom, when, and take that into consideration when making choices with your doctor, with your clinician about what to do. And maybe it's not a medication, maybe it's a therapy, what it is. But I think so. We have some similar tenets as precision medicine. We don't necessarily get into the genetic predisposition, those genetic pieces, but we sort of live in that universe as well. That's a great question. Thank you.
That's all the time we have.
Okay, thank you.
And here.
Over here, here's the time. Yep. No, okay.
Okay. We are very excited for our next presenter who traveled from Northwestern to be with us today. Dr. Inga Burnett Ziegler is a licensed psychologist, and she's going to present on the approach of mindfulness with women. Thank you.
Good afternoon, all.
Good afternoon.
Thank you so much for having me here to speak with you today. As was mentioned, I am a clinical psychologist and assistant professor in the Department of Psychiatry at Northwestern, and my work really centers around understanding disparities in the prevalence of mental illness and treatment, and using a mindfulness-based approach in order to address some of those disparities. I'm certain that everyone in the room today understands that depression is among the most common of the psychiatric conditions and is associated with both mental and physical impairment, including role functioning at school, work, and home, chronic illness, cardiovascular disease, morbidity, mortality, and higher rates of suicide. We also understand that social determinants of health, meaning factors outside of the individual, community, and environmental factors, contribute to disparities we see in the prevalence of mental illness broadly and depression specifically. When we think about specific social determinants of health, we know that economic position, including unemployment, lower average income, and individuals that live below the federal poverty level are at increased risk for depression. Additionally, those with fewer years of education are at increased risk for depression. Those that are more likely to be exposed to racism and discrimination, and in turn have a heavier burden of chronic stress, are at increased risk for depression, as are those that are under-resourced in that they lack health insurance and availability of healthcare providers in their neighborhoods. And a number of the large-scale epidemiological studies show us that when controlling for race and ethnicity, the prevalence of depression and a number of the other most common psychiatric conditions are equal. However, we do know that African American and the Latinx population are less likely to have a college degree, have higher rates of unemployment, lower average income, higher rates of poverty, and higher rates of being uninsured, making them more vulnerable to developing mental illnesses broadly and depression specifically. We also know that the majority of folks with mental health need do not receive treatment. Less than 50%, most large-scale studies show us, receive treatment, and African American and Latinx population are even less likely to receive treatment. Those that are more likely are women and people that are sicker. They've had a previous depression diagnosis, more psychiatric comorbidity, more symptoms, and have experienced their symptoms for longer periods of time. Alternatively, those that are less likely to get treatment are men who are younger, racial and ethnic minorities, and those that are under-resourced, fewer years of education, lower levels of income, and uninsured. And in that way, many ways, those that are at higher risk for developing mental illness are also those that are least likely to access the mental health service system. There are a number of barriers to treatment, and I like to think of barriers in terms of concrete and psychological factors. So the concrete factors are things like the cost and the availability of providers, but the psychological factors are things like how one sees themselves, them being able to identify themselves as having a need for a mental health treatment, believing the problem will get better on its own, wanting to solve the problem on your own, believing that mental health treatment will not be effective. Stigma concerns about being perceived as crazy or weak, concerns about the side effects of medication, that it'll be addictive, or that one will have to stay on a medication long term. And the literature tells us that racial and ethnic minority populations are more likely to have these negative attitudes and beliefs around mental health treatment broadly, and psychiatric medications specifically. We know that most folks that do get treatment, those that do access some sort of treatment for their depression, are most likely to get it in primary care. However, there are some limitations to receiving mental health treatment in primary care in that antidepressants are the most commonly offered treatment. And adherence is imperfect, the response rate is low, and some folks just don't want to take medications. And specifically, racial and ethnic minority adults are less likely to prefer medication and more likely to prefer counseling. And this is particularly relevant when we think about the perinatal population, understanding that many individuals during the time of pregnancy and breastfeeding are less likely to be amenable to taking a medication during that time. And so I want to shift gears. The work that I've been doing in terms of my research focus has been to, given the things that I've just discussed, my research program has been working to close that gap, understanding those that are most risk for developing mental illness and those that are less likely to receive treatment. And so given that those that with lower socio and economic position and racial and ethnic minorities are at increased risk for depression and less likely to participate in a conventional mental health treatment and more likely to go to primary care, a novel evidence-based mental health intervention such as mindfulness might be more accessible and acceptable in the primary care setting. So I think that many in the room might be familiar with mindfulness, but just for a 15-second review, one of the most commonly accepted definitions of mindfulness put forward by Jon Kabat-Zinn is being aware in the present moment in a particular way, on purpose, and non-judgmentally. And mindfulness-based stress reduction is an 8-week structured intervention that was developed in the late 70s by Jon Kabat-Zinn for the treatment of chronic pain and is now being delivered worldwide in both community and healthcare settings for a number of physical and mental health conditions. However, it's expensive. Any of us could go sign up for a MBSR program and it would run you roughly $400 to $600 to participate. We know that mindfulness-based interventions broadly have been shown to improve physical and mental health, and the U.S. Department of Health Care and Human Services recommends mindfulness-based interventions as a non-pharmacological treatment for the management of depression. Improves stress, anxiety, depression, lowers blood pressure, heart rate, in general population as well as the perinatal population. And so for the past several years, the goal of my work has been to adapt the evidence-based MBSR developed by Jon Kabat-Zinn for a community healthcare center setting. The first goal of the pilot work was to adapt the surface content of the standard MBSR intervention. The second goal was to be able to train embedded health educators within the community health center setting to be able to deliver the intervention. And the third goal was to be able to pilot test this 8-week adapted intervention to see, is it actually true? If you build it, will they come? Because we know that there's a problem of not only availability of resources, but also those psychological barriers that might prevent one from accessing resources if they are in fact made available. The setting in which I was conducting this work is on the south side of Chicago, where about a third of the residents are single parents, about a third have a high school education or less, about 26% are unemployed, and about 40% are living below the federal poverty level. And the way I've broken out this information here, in body are the participants that were in the intervention. Oakland is the neighborhood in which the research was conducted. And then in the third column there are the overall Chicago statistics. So when we look at this neighborhood in our study population specifically, we see that they're generally more disadvantaged than Chicago overall. However, in the complete framing of Chicago, kind of not the most impoverished of neighborhoods. All of the participants in the study were women, and the vast majority of them were caregiving. Some of them, about 83%, reported having children. Of note, of our participants, many of them were caring not only for their own children, but also caring for grandchildren and great-grandchildren. And stress was something that we measured in the study, and caregiver burden and stress was something that was commonly reported among our participant population. As I mentioned, one of the goals of the work was to adapt the standard intervention for delivery in a community health center setting, understanding that most folks are not able to attend a 2.5-hour per week intervention. So we shortened the intervention from 2.5 hours to 90 minutes per week. We also got rid of the weekend retreat. That's a standard part of MBSR. And we also tailored the surface content to make it reflect the participants that were coming to the study, using images of African American women, as the majority of our participants were African American, and using examples and other poetry and the like that would resonate with a majority African American population. The significant adaptation that I'd like to underscore is the training. You may be aware to become a certified mindfulness instructor requires about 2 years and at least $10,000 and a significant amount of time. And that level of training is often just not feasible for anyone, and particularly among community healthcare providers. And so what we sought to do in this work is to develop a mindfulness crash course that we could use to train embedded community healthcare providers, and they would then deliver the content to patients in their healthcare center setting. I want to briefly talk about what we found. And so the work was to look to see not only did participants benefit from the intervention, but were the outcomes different based on the level of teachers trained, right? And so, in short, we found that teachers that went through the crash course training or the streamlined training had comparable outcomes to those that had more experience, not only as clinicians, but more experience in mindfulness. We saw that across the 4 groups, participants showed a reduction in depression, and although there was some return to their baseline at 16, although there was some regression at 16 weeks, they didn't return to their initial depression scores. Additionally, we saw increases in mindfulness across all of the groups, and most of that increase was sustained at the 16-week period. Additionally, we saw reductions in stress and reductions in PTSD symptoms. And I just want to make a note about the PTSD piece here. You see there's only 2 lines. That's a measure that we added on about halfway through because this intervention was initially developed to treat women with depression. And over the course of the work, we had lots of women talking about their trauma experiences. And so we thought it important to measure that and measure the impact of the intervention on trauma over their duration of participation in the study. Finally, we saw that well-being improved and functioning improved as well. One key component of MBSR and the adapted intervention is the home practice. And so with many structured interventions, it's difficult to get folks to practice at home, and our experience was no different. We found on average participants practiced roughly 3 or 4 days per week and tended to enjoy the body scan or the body visualization exercise the most. And so finally, we really wanted to hear from participants. Our previous speaker was talking about patient engagement. We really wanted to hear from participants around, is this something that you found beneficial? Is this something, and how can we further tailor the intervention to best meet your needs? And we found that most of the participants were not familiar with mindfulness. We know in many settings now, mindfulness is kind of a buzz term that we hear, but among the ladies that I was working with on the south side of Chicago, the concept was new but intriguing. Additionally, participants reported that they benefited from the practice. It helped to calm them, manage anger, help them be in control of their thoughts, emotions, and behavior. They appreciated the social support, and they appreciated being able to take time for themselves. And finally, a key component was to learn how we could further adapt the intervention to best meet the participants' needs. I know many of us that work in intervention development are thinking about ways to shorten our programs, and interestingly enough, participants actually wanted more sessions. And as we've continued this work, that theme continues to come up. Participants are asking for either an intermediate level group, a peer-led group, something that is structured that will allow them the framework to continue their practice. Just a couple notes on future directions. We are fortunate in that this work is now being funded by NIMHD to be studied as a randomized controlled trial against usual care. I'm excited to announce we just finished our first randomization, and engagement continues to go quite well. And so really looking forward to see how this type of embedded mindfulness-based intervention will pan out against the standard of care in community health. Additionally, looking to examine populations that experience depression, but also other chronic health conditions that are highly comorbid among low-income racial ethnic minority women, specifically a hypertensive population. So have a study in progress now to examine the effectiveness of a mindfulness-based intervention for stress among adults with hypertension. And finally, currently working to adapt this work for implementation in a case management program for pregnant women that are living with HIV. So continuing to think about other high-risk populations that have a high burden of stress, low engagement with mental health services, and ways that these types of interventions and others can be embedded into existing structures in order to improve access and engagement in care. Thank you again for your time and attention, and looking forward to the rest of the day. Any questions?
I only have time for one question.
Okay.
Please make it a good one.
I work with a very similar population, and we find that our barriers to programs like this are things like buy-in and lack of access to transportation. Did you offer any supports to those types of things in order to secure engagement?
So buy-in by the community provider or by the partner?
So having them be motivated to come to the first session and then
Sure.
continue to come.
Sure. So I think that the pilot work really helped with that. And since the pilot work spanned the period of 3 years, it really allowed an opportunity for us to become a familiar presence in that health center setting. So our flyers have been floating around for years. There were participants that were sending their sisters, mothers, daughters to participate in the program. So that pilot period really allowed us to already kind of be embedded. And I think that that reduced some of that type of barrier in the health center setting. Additionally, the research staff do a lot. They do a lot of calling, a lot of texting, a lot of, we miss you so much, what can we do? And, yes, so that's another strategy that we use to improve engagement. And you mentioned transportation. We do offer public transportation cards and meals and nice swag for participants that come as well. Thank you so much.
I want to say something a little special for Dr. Zivins' introduction. So most of the room knows this is World Maternal Mental Health Awareness Week, right? It started on Wednesday. The way that we kicked off this week around the world is we had Dr. Zivins' paper come out. And it gave credence to a lot of the work that we do. She published a paper on the untreated cost, or the cost of untreated perinatal depression and anxiety disorder. So we're so excited that she's here. Hopefully you read that paper. We sent it out on the coalition listserv, but thank you.
Thank you for having me. So I realized sitting here that I probably have twice as many slides as I can really get through, so I'm going to skip through some background because I think we all are probably aware of the burden and issues related to, oops, I pushed the wrong button. Okay, so this topic is in the news, not just perinatal mental health and medications, opioids, suicide. So I'm just going to skip all of this. I was going to tell you about being a health services researcher, but what I wanted to get to in the main part of my talk was talking about some policies and then some studies that we're doing related to that. So I was excited actually to come to Illinois because Illinois is one of the leaders, I think, in terms of the longevity of policies that have been advocating for screening and treatment for perinatal mood and anxiety disorders. But I thought, since I said my talk was going to be about policy, I wanted to go through with you some of the developments over the last decade or so to show that we really have made some progress. Then the work that I'm trying to do is evaluating the impact of these changes in policies on access to care and quality of care and outcomes. But so starting in 2010, the American Academy of Pediatrics came out with a recommendation to screen for depression in pediatric practices, which at that point, only 13 states implemented, but that's a point of care where many women who might be struggling, they still might take their children to the pediatrician, and so that is an important point of access to care, although there does remain the question of what happens if you do screen positive in a pediatric practice, because pediatricians are not necessarily going to treat the mother. Then in 2012, the American Medical Association came out with a recommendation supporting improvements in mental health services as well as insurance coverage. And so that always makes me pay attention, because many things, while we might want people to be screened and treated, insurance coverage is what drives whether they actually will be, so that providers can be reimbursed. And then in 2017, the AMA added anxiety, psychosis, and substance use disorder, so thinking about a broad array of behavioral health conditions during the perinatal period. Then in 2015, the American College of Obstetricians and Gynecologists also joined on with these types of recommendations, thinking about screening both during pregnancy and postpartum, and then also recognizing that it's not enough to just screen people. That's a first step, but if we don't link people to treatment as a result of screening, then it's not very helpful to anyone. Then moving forward, in that same year, the Association of Women's Health Obstetric and Neonatal Nurses also recommended screening and treatment, as well as appropriate referrals, training, supporting. So again, building out this idea of thinking about addressing perinatal depression. Then in 2016, the U.S. Preventive Services Task Force recommended screening, and this was important because under the Affordable Care Act, providers and practices needed to do screening as it was recommended with what's called a B rating, so A and B rated recommendations from the U.S. Preventive Services Task Force must be covered under the Affordable Care Act as part of the essential health benefits. And so that was another way of increasing attention to this issue. That same year, in 2016, the Centers for Medicare and Medicaid Services reissued some of the similar guidance to what the American Association of Pediatrics had recommended, that screening should be covered as part of a well-child benefit under Medicaid. And so again, that was another way in which drawing attention to this issue, and by then 37 states as of 2017 have implemented these policies. So we're making progress from where we were in 2010. And this is my last slide on policies. Then the Council on Patient Safety in Women's Healthcare created what's called a maternal mental health bundle. They have a number of different bundles related to perinatal health, and this one is focused on recognizing, responding to, and treating perinatal mood and anxiety disorders. And I realize I'm using these terms interchangeably. At first, earlier on, people focused primarily on depression and sometimes even only postpartum depression without recognizing that people could be depressed during pregnancy, and then it has been expanded more recently to include anxiety. Just last year, actually, the American Psychiatric Association joined in recommending screening, treatment, and follow-up. And actually, one of my colleagues recently was saying to me, why did the APA wait so long to join into this, which is a good question that I don't have an answer for. And then about a couple months ago, the U.S. Preventive Services Task Force came back again, and here they were recommending that clinicians screen and refer pregnant and postpartum women to counseling, which I thought was an interesting move. And again, this is another benefit that because this had a recommendation from the U.S. Preventive Services Task Force, also needed to be covered under the Affordable Care Act. Now, granted, we never know exactly what's going to stay related to the Affordable Care Act, and so some of these things could be at risk, but I think it was important to at least understand where the policy landscape is. So in this context, I wanted to share with you a couple of different projects I'm working on in different stages on this related topics. So the first one is a funded project that we're doing in Michigan. I'm at the University of Michigan, and we wanted to look at trying to understand unmet needs. So typically people like me use large data sets, Medicaid data or private insurance data to look at treatment for people with various disorders. But what you don't know from those types of data sources is who has not come for treatment. And so we wanted to merge survey data where women were asked about depression during pregnancy and postpartum, and then follow those people to see among the people who had these self-reported symptoms, how many of them actually got treatment and how did they look compared to the people who did not get treatment. So this is funded by a couple of different organizations, and we were linking PRAMS data, which some of you may be familiar with, but it's a CDC-based survey that's been going on since the late 80s, and we're using specifically the Michigan version of this survey and linking it to Michigan Medicaid. And while this may sound not that complicated, it took me over 2 years of fighting to get the ability to link these data, some for good reason because of concerns about patient confidentiality, but it involved a lot of maneuvering, shall we say, with the state partners. But we finally, just in the last month, have gotten approved to do this work. So in case, just a little more background on PRAMS. PRAMS samples women in each participating state based on deliveries of live births, usually 1% to 2% of mothers in the state. And there are specific questions around pre-pregnancy depression, perinatal care for depression, services, and then depression since the baby was born, as well as some other characteristics that you can't typically get from administrative data like breastfeeding. Then Medicaid administrative data is what you might expect in terms of having information on inpatient care, outpatient, and pharmacy data. So here, we're going to link together these sources and try to understand in a representative sample, which is the PRAMS data, understand what factors are associated with depression symptoms, as well as how those women are similar or different to all Michigan Medicaid beneficiaries. And then in addition, we're going to look at cost outcomes. I realize I'm going through this fast. There's so many different things I wanted to cover today. But anyway, so the point of this particular study is to try to get at unmet needs. And part of why I wanted to mention it here today is because I have this hope that maybe we could do something similar in Illinois or in Iowa or elsewhere and compare states, especially states with that have more forward-thinking or longer-term policies than Michigan. We also, I'm interested in the 2016 survey, which we did not use. They had information on self-reported substance use and actually individual substances, which I thought was interesting. And I found out from our state partners that they will let us link to infant data. So I think there can be some really cool work here if people want to spend several years fighting with their state to get their data linked. Anyway, a second study I wanted to mention is, it's promising, but I don't want to jinx it, potential funding from NIH, and this is actually using private insurance data. And here we were interested in trying to understand whether policies such as lack of insurance coverage could be attributed to insufficient use or under access to treatment during the perinatal period and postpartum. And we don't know of any studies that have specifically tried to document the impact of both mental health parity and the Affordable Care Act on women with perinatal mood and anxiety disorders. So we're using a data set called Optum, which uses United Healthcare data, which is one of the largest insurers in the United States. And we have data for 18 years. So we wanted to look at the impact of both mental health parity and the Affordable Care Act on things like mental health utilization, delivery outcomes, and expenditures. And I keep calling them federal mental health policies because I was literally told by NIH that I'm not allowed to use the word Affordable Care Act because it is so politically sensitive. So I just keep calling it that, and in the grant, then we can mention it. But so this may be hard to read, and I hate when speakers say that, but the point of this was just to say that people have been talking about changes in coverage for mental health for more than 20 years, if not longer. And each of the policies here and the relevant acronym is just to say that we have been chipping away at trying to improve access to mental health care coverage. So parity would mean that coverage for mental health conditions is the same as for physical health. And while maybe to some of us that might seem obvious as it should be that way, it hasn't been. But both the mental health parity related legislation and the Affordable Care Act have made improvements in this area. So this is, we think, potentially relevant because if we see changes looking over time in access to care and potential outcomes among these women, that might help bolster the arguments of maintaining or extending policies as well as coverage for mental health conditions for this population. And finally, I wanted to mention a third project, and this is actually a project I'm hoping to work on with Dr. Tabb Dina about disparities in utilization and delivery outcomes associated with thinking about state policy making, whereas the previous study was thinking about federal policy making. So we are not aware of any data source that focuses on the magnitude, predictors, or variation in disparities, not only by race and ethnicity, but also by socioeconomic status and geographic location, and focusing on how those different factors affect utilization and delivery outcomes for women with perinatal mood and anxiety disorders. So we wanted to look not just at administrative data related sources such as private insurance and Optum and Medicaid, but also link survey data and community data such as the number of mental health providers or the distance it might take to get to a location where someone could get treatment. And so here we were splitting our aims to look first just at patient factors that we could get in clinical data and then merging on community level data. And then the part of this that I hope will be interesting is we will actually be building almost like a dashboard to show different states how they're comparing on various metrics. We will meet with an external panel of experts in this area, and then we will talk with state policymakers in high and low performing states. So this is a potential example. There's nothing intentional about the colors of these particular states, but just to say that we could show them, okay, your state, how does your state compare on this metric compared to other states, to see where there are examples of states that may be performing well and states that are having more challenges and opportunities for improvement. And so here we're hoping, again, as I just said, we can use this as groundwork for future implementation of effective state practices to share nationwide. So as we just talked about briefly, this is Maternal Mental Health Week. I don't know if you've timed your conference to sort out that, I guess that would make sense. And one thing that, from my perspective, so I'm not a clinician, but as someone who's spent, 20 years studying health policy and health services research is, we need more than just, while it's wonderful that we're drawing attention to it, we also need there to be action in terms of, how are we going to actually implement detection and treatment and linking people with treatment? And so while I'm glad, for example, Michigan and other states have declarations and other things, there needs to be more teeth, I think. we mentioned this issue brief. You can't see it, but this is what it looks like. In a different part of my life, I work at somewhere called Mathematica Policy Research, where we developed an issue brief. This was a really cool project where it was funded by 3 different foundations that they specifically wanted us to build a model using publicly available data. And the big message of this is that we found that from conception to age 5, using both medical-related costs as well as other costs, we found that $14 billion is associated with the cost of untreated perinatal mood and anxiety disorders for a given year of birth. And many of those costs actually have to do with women either becoming unemployed or decreasing their function at work or missing work. And so I think it's important to recognize the entirety. It's not just about, did you get this visit or that, but we also included things like access to social services. So, and we focused on both costs associated with both women and children. So, hospitalizations, preterm births, cesarean delivery, those things. But we also brought in a variety of other costs. So this is free and publicly available at this link. Finally, this is my hardest slide, but this is my son. He is 8 years old, and he is why I'm doing this work. I thought, especially for this audience, you might want to know that in addition to my work as a researcher, I had a very severe case of perinatal mood and anxiety disorders when I was pregnant with him in 2010 and 11. I was suicidal, and he and I nearly both died. And so to me, even though it's been really hard for me to talk about this publicly, I think it's important to try to break the stigma and also to think about how I can give back in this area. And I'm not going to get too emotional, but anyway. So just to say that I'm happy to be here with all of you, happy to talk further about this work, and I'm glad that so many people are here doing this type of work. So thank you for having me. I guess I can take questions.
We have time for two short
Yes,
questions.
I see one in the back.
Thank you, and especially thank you for sharing your story at the end. I work in Chicago with mothers who live in neighborhoods with high levels of violence and who lost children, lots of abuse and things like that. And so I'm interested in, and also have a background in policy, so I'm interested in having the mothers at the table thinking about policies that will help them. And I was wondering, in your work, right, I see that you took the data and you tried to make it accessible to people, but also do you have things like many think tanks or places where people who have lived the experience can say, this is what we needed, this is what I need, and actually use their leverage to try to put teeth in the policies and to hold their legislators accountable?
So I would love to do that, and honestly, that's part of why I'm here, especially, related to this PCORI-related work, because I admit that I tend to be the kind of researcher that sits behind a desk and works with statisticians, and it's very dry that way, right? And so coming here and getting to talk with all of you, and I was excited to hear from the patient panels, because I think so many of us who've been through this, feel so isolated, and yet coming together and hearing about, gee, I really wish when I went through this, it would have been this way, or I can't believe my doctor said this to me. I mean, I could tell you stories. I'm sure we could all tell stories. And so I haven't harnessed that in my research. This has been somewhat a mid-career shift for me. I was focusing on older adults and veterans, and I sort of reached a point where I thought, you know what, this is what I'm really passionate about, and I want to do this. But I welcome hearing more from all of you about it. Okay.
One more question.
Well, we'll keep ourselves on time and keep going, but I'm happy to talk later. Thank you.
So Jessica Johnson is also from Northwestern. She's going to present on another PCORI-funded project. This one?
Yeah.
Okay. Some of you had the pleasure of hearing her speak last year, so she's back by popular demand. Thank you. And here's your pointer.
All right, so thank you, Leah, for kind of giving us a shout out earlier. As Karen mentioned, my name is Jessica Johnson. I'm a research manager. I work with Dr. Tandon at Northwestern University on a mothers and babies intervention, which I'll talk a little bit about today. So as Dr. Zivin mentioned just a few minutes ago, back in February, the U.S. Preventative Task Force Services came out with a recommendation on the prevention of postpartum depression. Essentially, this recommendation concluded with moderate certainty that counseling interventions that prevent PPD do have a moderate net benefit for women who are at risk. While the task force recommendation did recommend more preventative work and interventions, one intervention that has shown success already in preventing depression and reducing depressive symptoms is mothers and babies. And we were excited that we were actually one of 2 interventions that was called out in the task force recommendation. So I'm going to talk a little bit about our intervention today, as well as some research we've been doing over the last 3 years. Sorry, I developed allergies this last year and my throat gets so dry. I think I'm okay for now, but thank you. All right, so a little bit about our intervention. So Mothers and Babies is a program that promotes healthy mood, bonding with one's baby, and really helps mom manage the stressors in her everyday life. So it's really related to issues in the pregnancy and postpartum periods, with the overall goal of reducing and preventing new cases of major depression. So Mothers and Babies is a cognitive behavioral therapy intervention, and it uses various cognitive behavioral therapy, approaches with moms. So this is primarily done in 3 ways. We encourage mom to do pleasant activities. So that's either on her own, with her baby, with her other children. This could be as simple as even taking a shower or taking her kids out to the park. We really focus on reframing our harmful and negative thoughts and turning those into encouraging and helpful thoughts, because we all know that our thoughts affect our mood, and our mood is affecting how we feel and how we behave. And then we also focus on talking a lot about increasing your social support system, what that looks like, talking with moms about who are the people in their lives that are their support system, and helping them identify who those people are. So overall, our intervention is framed as a stress reduction intervention that really focuses on the relationship between mom and baby. Mothers and Babies can be delivered in 2 modalities. So one of our most, common or popular modalities is delivering mothers and babies one-on-one between a home visitor and her client. This is really feasible and convenient for most of our home visitors, as it's over a 12-session period. So whenever they have their usually scheduled home visits, they'll spend about 15 to 20 minutes of each of those visits going over some of the mothers and babies content with mom. My expertise is in the group modality, which I'll talk a little bit about later on in my presentation. So this can be delivered with moms, usually about 5 to 8 women in a group. They meet for 2 hours a week for 6 weeks, and this group can be delivered by a home visitor or a mental health professional. I'll talk about that more later. So why do we need mothers and babies? Why is it important? Most early childhood programs only screen and refer for postpartum depression, and as we chatted a little about earlier with a few other speakers, we know that few women actually access these services when they're being referred to mental health services in the community. Now, Inger talked about this a little bit, but some of the barriers that women are experiencing. So there's a lack of mental health professionals potentially in their community, that stigma that Inger talked about accessing these mental health services, and then even the logistical challenges of mom being able to find transportation to get to the appointment or childcare for her other children. So Mothers and Babies really helps develop the skills of the early childhood program staff who are already working with moms to be able to address these issues of depression and anxiety. So Mothers and Babies is easily integrated within early childhood programs and just acts as an overlay or as an addition to what our home visiting staff or community health workers are already chatting with moms about. So as Karen mentioned, I had the privilege to speak last year at this symposium, and when I spoke last year, I just spoke on the very beginnings of our work, and I'm pleased to announce that a lot has happened over the last year. We've had, the last 6 months or so, Mothers and Babies has been pretty, what we're saying, hot in the media. So as I mentioned earlier, we were named in the U.S. Preventative Task Force statement. Dr. Tandon, who is the principal investigator for all of our Mothers and Babies work, also co-wrote an editorial for that recommendation, which you can see up here. And then excited to report, and Leah mentioned this earlier, we were mentioned, or we were featured, I guess, in a New York Times article a few months back. And for me, what is so exciting about this, not only are we getting the word out nationally about mothers and babies, but as you can see here, Captoria Porter and her beautiful family. She is one of our, not only one of our previous Mothers and Babies participants, but she is actually one of our patient stakeholders on our PCORI project, which I'll talk about a little bit more today. And she has just been invaluable to our study and what she's brought to the team from her perspective as a mom. So we were really excited that she was featured in this article. All right, so I'm going to switch gears and talk about the research that I have been working on the last 3 years. So I do want to mention that previous research has established effectiveness of our Mothers and Babies intervention when facilitated by a mental health professional. And there have been studies that have compared the effectiveness of various CBT interventions between professionals and lay health workers when looking at the treatment of depression and anxiety. But to our knowledge, there haven't been any studies in the United States that have really focused on lay health workers preventing depression. So I'm going to talk about a 3-year PCORI-funded study that we have been working on that will be wrapping up the end of the summer. So we had 3 aims for our study. First, we wanted to compare the effectiveness of the group modality of mothers and babies compared to usual home visiting care. So of course we know that usual home visiting services don't include mothers and babies. We also wanted to compare the effectiveness of mothers and babies when delivered by a home visitor versus a mental health professional. For the purposes of our research study, we defined a mental health professional as someone as having a degree in a related field, so social work, child and family studies, psychology, etc., and a minimum of 5 years experience working with women and children. And then we wanted to look at examine how feasible and acceptable it was going to be for mothers and babies to be delivered by both types of these facilitators. All right, so the exciting stuff. We began our study in August 2016. Over about an 18-month period, we were able to recruit 874 women across 36 home visiting programs in 7 states in the Midwest. We recruited and trained 53 facilitators who delivered the intervention, and 32 of those facilitators were home visitors and 21 were mental health professionals. And our amazing facilitators completed 133 cohorts or 133 mothers and babies groups over that 18-month period, so between January 2017 and October of this past year. So I want to give a little snapshot of what the women in our study looked like. So we felt that a major strength of this study was its inclusion of a racially, ethnically, and geographically diverse set of women. So all of the women enrolled in our study were either enrolled in home visiting programs or actively trying to enroll. They were 33 weeks gestation or less upon referral into the study, and they were English or Spanish speaking. So as you can see here, the mean age of a woman enrolling into our study was 26 years old. 36% of our moms were first-time moms. 45% identified as Black, African American, 30% as white Caucasian, etc. And the primary language spoken in the home was primarily English at 84%, and then we did have 14% of our participants who were Spanish speaking. So as I mentioned earlier, typically our mothers and babies groups, we like to have about 5 to 8 women. Due to the small caseloads of our home visiting programs that we were working with and other barriers like transportation and childcare, we ended up having on average about 3 women per group. And at first we weren't sure how that was going to work, if it was going to be acceptable to moms to have such a small group. And I'll talk a little bit about this in a few minutes when I touch on our qualitative analysis with the interviews with our moms, but women did report that they actually preferred the smaller groups because it helped them trust and build that camaraderie among other women in the group to be able to share their experiences. So facilitators implemented between 1 and 12 cohorts, but on average each facilitator implemented about 2.5. Try to get through this quicker. This is just a quick snapshot of our study timeline. So quickly again, we started implementing and enrolling in January 2007. We completed enrollment and implementation in October of last year. I did want to mention that upon enrollment into the study, we did ask mom to complete surveys at 4 time points, so at baseline before she received any intervention. Post-intervention, so we collected information through the quick inventory of depressive symptoms, the kids, 1 week after mom finished group. Then the babies were born, and we asked mom to complete surveys at 12 and 24 weeks postpartum. So we will be concluding our data collection at the end of July. We'll be doing our analyses in August, and then hopefully reporting on our primary outcomes at the end of the summer, early fall. Okay, so quickly, I wanted to share some of our preliminary data that we have. So this slide is showing group adherence or dosage data. So we said that a mom was adherent to the intervention if she attended at least 4 out of the 6 sessions. So as you can see here, overall adherence was about at 54%, which is a little bit lower than in previous studies. However, this study does have a much larger sample than a lot of our previous research. Something interesting on this slide that you can see is the Spanish-speaking women and our women that lived in rural geographic locations actually had higher adherence to the intervention than their counterparts that, majority lived in the greater Chicago area. And I know a lot of us have experience with challenges implementing interventions in a rural geographic location. So this was interesting to us. So we talked with our patient stakeholders and our community advisory board on why they think this may be the case. And one suggestion that they had was that these women potentially that live in a more rural geographic location, and even our Spanish-speaking moms, have potentially less access to resources or opportunities like this to participate in compared to their counterparts that live in the city. And then you saw on the previous slide, our Spanish-speaking sample was much smaller than our English-speaking participants as well, which could have also contributed to this data. So we wanted to hear from our participants outside of their survey data. So we conducted interviews with 88 of our intervention participants, both English and Spanish speaking. 45 of those women had mothers and babies delivered by a home visitor, and 45, and then 43 had mothers and babies delivered by a mental health professional. We interviewed 48 facilitators. The reason we couldn't interview all 53 was due to scheduling conflicts and interest among our facilitators. We had research staff interview the moms and the facilitators via phone. These interviews were then transcribed and then coded using in vivo software, and we used a thematic analysis approach when looking at our data. So next, I just wanted to share a subset of themes that came out of our data from these interviews. So participants and facilitators found the MB materials to be acceptable. So I have a quote here. I won't read the whole thing due to time, but essentially participants really valued the role that their facilitators played in their acceptability of the materials. Facilitators voiced challenges with the implementation of the group modality when participants brought up issues of homelessness, crises, or trauma. There's a quote here from a facilitator. She says, "I think each group facilitator should at least be aware that those stressors are real and that they should have resources to refer to because it will come up. If a mom has the stress that she's homeless, it's hard for her to focus on a group if she's having other stressors." So this came up a lot, kind of balancing the fidelity of the intervention and what they were supposed to be delivering versus the actual real life situations of moms that were coming up in the group. And lastly, I touched on this earlier, participants really enjoyed meeting the other women in the group and building their support systems. And as I mentioned, the small groups ended up actually being an advantage to this as moms felt more comfortable in sharing with others and creating those bonds. So I do want to read just a part of this quote because it's one of my favorites from one of our moms. She said, "I would say because before I started the mothers and babies class, I didn't really have any pregnant friends I could call or ask for advice. But now I'm actually in touch with all 3 of the other girls from the group. We talk almost every day," which as a researcher, it's really nice to get out of the data and really hear from the moms and hear that, you know, they're making friends with others and growing their support system. And lastly, I wanted to share some facilitator fidelity data with you. I'll go over this really quickly and just highlight the main takeaways because I think I'm almost at my time. But we did end up audio recording all 133 mothers and babies groups. We selected a subset of those randomly, about 20%, that we wanted to rate for facilitator adherence and competency to the intervention. So we do have a manuscript right now being considered in BMC psychiatry talking about our entire fidelity process, so I can share that with anyone who's interested due to time today with the actual process. But essentially we rated adherence and competency using a modified version of the revised cognitive therapy scale. And overall adherence for all of our facilitators ended up being 77%, so how well they actually delivered the intervention as it was intended to be delivered. Exciting for us, the average adherence for the home visitors was actually slightly higher than the mental health professionals at 79% versus 74%. And then we also wanted to look at facilitator competency, so their skill level in delivering the intervention. And this was over the 12 competency items in the scale that we used, rated on a 6-point scale, 0 being poor, 3 being satisfactory, and 6 being excellent. So as you can see here, overall the social emotional categories seem to score the highest, but really the most exciting and biggest takeaway is if you look at the home visitors in yellow, they were just as competent or more competent than the mental health professionals across the board on all 12 competency items, which is very exciting for us because if you remember back to our aims, one of our aims is to show the effectiveness of home visitors versus mental health professionals in delivering our intervention, and this is just one step towards that aim that we are excited to find. So main takeaway is that with the proper training and supervision, home visitors are just as competent as mental health professionals in delivering this preventive intervention. So where do we go from here? So should we find that receiving mothers and babies from home visitors show better mental health outcomes or similar mental health outcomes as usual home visiting care or mothers and babies delivered by a mental health professional, there's considerable potential to be able to expand this intervention nationally. So as I mentioned earlier, we're planning to disseminate our final outcomes at the end of this summer and this fall, and currently we are trying to explore how we can sustain the intervention at our current home visiting programs when the research study comes to an end this summer, and how we can promote the spread to other programs as well. Okay. I won't mention this, but we did receive a fundable score for a grant to continue this work to follow all of our babies from this cohort through 4.5 years. I want to thank PCORI, and thank you very much.
So, I'm going to say if we have questions, if we could ask Jessica on the break, because I know how people are with breaks.
Yep.
Okay, and we'll come back 5 minutes late, so we'll come back at 3:50 back to this room. We're going to have an expert patient panel. Thank you again.
Thank you.
On this work, we both have involved patients in our research and stakeholders, and so some of my board members have graciously agreed to come to the meeting and have traveled from the University of Iowa today to be here, and you'll hear from more of my board members tomorrow as well. And we also have women from the IDEA Coalition, so Karen's patient advisory group, that are here today too. So we wanted just to have a couple of sessions, and the one today is on the motivation and reason for being on an advisory board. So really kind of just letting you hear from the patients that have been involved in these advisory boards on why they got involved and what their interests were. So I'm going to start out just asking you each to introduce yourselves, where you're from, so which group you belong to, and then maybe start out with how did you learn about the advisory board or coalition activities. So you can start right here.
Hi, I'm Sheila Rayla. I'm a registered nurse and I work at Champaign Public Health. I've been there about 17 years working as a nurse case manager for low-income women from pregnancy through the baby's first 12 months. We work with a grant that's designed to reduce infant mortality, improve birth outcomes, and that kind of thing.
Just use the microphone.
Thank you. My supervisor, Brandon Moline, has worked with Dr. Tabb for a number of years on several projects, and that's how I learned about this one. I got real excited about it because we started screening women for depression a number of years ago, and it surprised me how many women would come in dressed, groomed, you look like everything's fine, you talk about the baby, and then they would score off the board on their Edinburgh, and I would ask them, what's going on? And they would burst into tears, and then I would find out what was really going on with them. I've seen changes in the community over that time where providers are becoming more responsive to women. But my clients have Medicaid. Typically, there's not a lot available. Just within the past few years, OBs are starting to treat women rather than trying to send them to a psychiatrist. So they're getting medication, but at this point, that's about all that's offered to them. I'm really excited about this project because, it looks like PCORI's goals are in sync with what I think needs to happen, that policy needs to change. We need to, look at real outcomes, what really affects people, and the fact that they actually want my clients involved in the project. They want to hear their voices. These women, a lot of them are women of color, they're low income, a lot of them are immigrants. They're a voiceless population that kind of gets missed. So I'm real pleased about that and to involve them. The last thing, too, is for a number of years before I worked at public health, I was a psychiatric nurse, and I worked with children from 3 to 10 who were behavior disordered, inpatient. And at that time, what I saw was the problem wasn't the children, it was the environment they came from. And this looks to me like an opportunity to work with them from the beginning. And mom is the beginning.
So I think this really has the potential to change the world. So yeah, I'm very, very happy to be here.
I'm Dr. Emily Lux, and I didn't know anything about postpartum depression. I didn't think I could get postpartum depression. I had a wonderful pregnancy. And then after my son was born, while I was in the PhD program, I had postpartum depression. I had a lot of childhood sexual and physical abuse. I went through the child welfare system, so when I was in the PhD program, my focus on my dissertation was child welfare, protecting sexually abused kids. Thank you. And then my son, I am Dr. Karen Tabb's department, the School of Social Work, and our kids are about the same age. And Karen and I were talking, and she asked me if I'd want to come to her pregnancy and postpartum expo last year. It was the first time they were doing it. And I said, sure, I'd love to. And that's how I learned about the advisory board. And I didn't know if there was anything I could offer, but I really wanted to try. And so I've loved it. And that's how I learned about the opportunity. I didn't apply right away. I, for some reason, thought it was going to be a ton of work. And it's not. It's a reasonable amount of work, and it's very enjoyable. But I was collecting data at that time, and I was like, no, I can't overcommit. But as soon as I stopped collecting data, this email popped in my inbox and asked if I wanted to apply, and so I applied, and it's just been so much fun.
All right, I'm Suzanne Peppers. I'm a physician assistant, but more involved in wanting to take part in this. I'm relatively new. This is actually my first function of anything dealing with any of this. So, but I really came involved in wanting to do something with this. I had a horrible third pregnancy, and I delivered at 23 weeks. I was that patient that failed every postpartum screen. And all I was offered was medication, but that was much further along down the road. My son was in the NICU for 4.5 months at the University of Iowa. It was a long haul, and so I'm here wanting to join to try to actually initiate things, because I had all of those screens at multiple appointments, and I'm sure I failed all of them, but nothing was ever actually implemented. So that's my driving force in wanting to take part in all of this. So that's all.
I'm Leslie Feener. I am with the Office of Outreach and Engagement at the University of Iowa, and joined the board. I think there was just a call for interested people, and several of us got together, and it was just interesting to hear. Everyone had a story. I mean, everyone has a story. And I personally have mental health issues in my family, and I'm also interested because I was a foster parent for several years for 11 kids, and about half of those were babies, and it just occurred to me how much had already happened in their little lives, and I just think, like you said, this is everything, this is about the whole world. So I'm excited to be on the board.
Could any of you also just talk a little bit about, and I think you all have addressed this a little bit already, but maybe why you are passionate about the work we've heard today, and why you've become involved in really studying these issues, or what you really hope to get out of this?
I'm hoping to see policy change. I'm hoping to see that, and social change, that there's a whole group of people that I think are missed. And I think it covers like women as, as a minority, women of color, minority, low income, minority. And this is a mental health and a public health issue that I think up until recently has just been kind of swept under the rug. I mean, we're hearing like people sitting right here at this table that have experienced it, and it wasn't really addressed, And I'm hoping to see the stigma removed. I'm hoping to see it covered by insurance, including Medicaid. I'm hoping to see the shame removed from it, where women don't feel that, they're defective or they failed if they experience this. It's complex. It's biological, it's psychological, it's sociological. And I want to see us as a society address that and support, I want to see the supports be put in place. And I'm hoping that the research is going to, show the need for that and lead to it.
I became involved in the board because after I was diagnosed with postpartum depression, I used a lot of the community resources. At first I was hesitant to use them because I didn't think they were for like women like me. And I'm so glad I did. And when I saw that the board was forming and I saw that a lot of the providers that had helped me were part of the board, partnered with researchers, and patients, it just made me really excited to have this holistic, really continuum of care working together. Everyone has input, organization. And as a researcher, as a newer researcher, I've always just thought, like, well, you research to get a PhD and you research to get tenure, and like your research just goes somewhere. No one reads it. People told me no one will read my dissertation. Like, no one reads it. And it's actually just really fun to be part of a group that really believes that research can really make an impact on policy and on practice. And that's just really exciting to see. So for me, it's the holistic, working with patients and providers and researchers, and then seeing that impact that is why I wanted to be a part of it. And that's like the most exciting part for me.
I'm not sure I have any more to add than I've already said.
I would just say the outreach and engagement aspect of this is interesting to me. Sharing the knowledge and the research with populations across the country. So,
great. Well, I think in the interest of keeping us on time, that's what we have for time. But thank you very much for sharing your stories.
So 2 things before I give your introduction. Right after this talk, please don't leave. Conference isn't fully over. We have posters and networking. We have appetizers and adult beverages. Brandon's taking my drink coupon, not PCORI funded. Thank you, Dean Anderson. So that will be back in the humanities room where you registered. And at that time, please bring your evaluation form and you will receive a gift. Okay, everyone receives a gift, like Oprah, right? You get one, you get one, okay? So our capstone presentation today, we're super excited about. We're so happy this team could come here all the way from New York to share with us the genesis of their project. So we have Elaine Bell and Ellen Poleshuck here. I'm going to turn it over to them. Thanks.
Hi, I'm just so excited and honored to be here. What an amazing afternoon you've put together for us. And I think we're already seeing the whole point here, which is that marriage of science and heart and personal experience being woven together. And so I'm just thrilled to get to be part of that. So thank you. So I'm Ellen Poleshuck.
I'm Elaine Bell.
And so we thought, Karen very explicitly asked us to talk about how did we come to work together, how did we develop our partnership and develop the trial that we developed with PCORI funding. So we'll walk you through that a little bit.
Actually, we're 7 years into a PCORI grant.
Yes.
Yeah, we're on our second one now.
Yes, that's right. So we have, this is only a few of the people in the photo, but it takes a village, and we're enormously grateful to the many people who have helped us be able to do this work, as well as to PCORI, who's been instrumental in allowing us to move this work forward. So in terms of funding disclosures, I've had funding from NIH or have funding from NIH and PCORI, and Elaine has funding from PCORI. So an overview of what we're going to talk about today. First, we just wanted to give you a brief overview of what the actual trial is, and then we're going to give a brief definition of PCOR, which we already got earlier, so we'll do that briefly. And then we're going to kind of walk through the background of how we got to the trial, and how we developed our partnerships, how we developed the methodology, and then, because we have to, we'll give you a few outcomes, because you'll want to know how that went, and lessons learned and next steps, and hopefully we've left enough time for discussion. What was our official start time? Okay. Go ahead.
Is that me?
Yes.
Oh, I got to read.
Oh, yeah, go ahead.
No, it's hard. My eyes are not good anymore. Okay. Yeah. Patient Outcome Center. Outcome.
Is it too hard to see?
Yeah, it all is.
Paper ones? Would that be better?
Yes. Yeah, I'll go. Okay. Yeah, I'm sorry. Yeah, the font is too small and my eyes are too old. I don't think we can make it any bigger without losing it. Nah, it's okay.
It's just they're all out of order, right?
No, they're all in order now.
They are in order?
Yeah, I renumbered them because you were playing with them.
But I think this is what is a...
Oh, what is the PCORI trial? I got it. We're gonna get there. We're gonna get there. All right. The patient center outcome research. It helps people to and their caregivers to communicate and make information and healthcare decisions. Boy, that's really important. When the partner is your patient and they're really your partner, it makes a big difference in how things are going to come out. Given the personal characteristics, conditions, and preferences, what I should expect, and what will happen to me. What are the options, and what are the potential benefits and harms to those? This is PCORI's definition, okay? What can I do to improve the outcome that is most important to me? And how can clinicians and care deliver systems, how can they work for best for the patient and the healthcare system? All right. Yeah, really.
Thank you. Is there...
Keep saying I can do this, I can do this.
Oh, dear. Okay.
I just lost.
I was trying to see if we could put it up here, because I thought that might work better. But now I've just messed the whole thing.
I just lost it.
It's thinking about it.
It's coming? Okay, sorry about that.
Here's your PowerPoint.
No, not really.
Oh, no? Really? You either?
I can do it from here. Oh, it's still not up there.
There it goes.
There, thank you.
There it goes.
Okay.
Okay. You got it.
Do you need the next slide? Yes, please. I think we're not. Okay.
Oh, now I can read that now.
Nope, you don't want that. Well, I need to get out of the way. That's the problem.
Here's slideshow.
We're all this time.
I think if we just go back to the top.
Remove it.
There it is, there it is. Okay, now. Sorry.
I'm going to do it.
Here's
I don't know how to use this mouse again. Is there anyone who knows
Where's
how
our
to-
IT guy? Is there an IT guy here?
No.
Oh.
But there's a professor in the house.
I'm just trying to get the slideshow to start again. Oh, look at what I'm doing. Now I'm making new slides. We've only made it to the slide like this. Okay, but we just need to start the slideshow again.
Do what?
Nope. Oh, no.
There, thank
Oh,
you.
great.
Okay.
Let's roll.
That's it. So, I'm fine, thank you. Okay, oh, this is still you. As a community member, why be involved in research?
Okay, I got it.
Really, we've got this.
Okay. The reason why I got involved is because we have an inordinate high low-income population in Rochester, more so than you would think for our population. And to me, that was the most important thing, to have every voice heard, and my own included. Learning how the process works, boy, that was tough. Research is so daunting, and it takes such a long time to get where we were going to go. 7 years we're doing this, 3 years figuring out the program before we even applied to PCORI. Having input in the process, I've always had input. I'm one of 3 in a patient leadership team, and our voices are equally heard at the table every time we sit there. Giving a voice to the patients with living experience, it's my experience. And they draw from it. They always ask, what do you think of this? And do you think we can do this? And I tell them, no, you know. And shaping the clinical services, we set up a prioritization tool, and we'll talk about that later. And that was a lot of work, but interesting. Go ahead. Sure, your turn.
And for me, why use a patient-centered approach? I think that the story I like to share when I think about why did I become to this approach to doing research is that I did a clinical trial that I was really excited about, and we had nice outcomes. It was an interpersonal psychotherapy trial for women with depression and pelvic pain, for low-income women's health patients from our pelvic pain center. And so we had nice outcomes, but we couldn't get anyone to be in the study. And so we had to screen so many women, and it was so hard to find women who were eligible and who were interested and felt able to commit to what we were asking them to do. And so I kind of, at the end, felt like, okay, well, this is great that they got better for depression, but how useful is this if they don't want what it is that we're offering and they're not using it? So what's the point of evidence-based interventions if they don't match what patients feel like they can and want to use for themselves? And so that was really kind of an aha moment for me that really moved me into this direction. And so this is kind of a list of the practical reasons that I think it has really helped, that I think by getting involvement from our partners from the very beginning, we did really well with recruitment and retention, which we'll show you the numbers with, because we were offering people something they wanted and that they liked, and we got strategies about how to try and keep them in the trial. And they liked it. And then we tried to pick outcomes that mattered to people, right? So the patients helped us decide what is it that we actually need to try and impact, instead of deciding on our own what's supposed to change. And then, of course, as Elaine already said, this is going to work, this isn't going to work, what are you going to think about? But also for me, it's changed the way I think about doing research in terms of the meaningfulness and the learning that I get to have, and that the whole point is to do research that matters, and our likelihood of being able to do work that matters is greatly improved by partnering together. So the trial, to give you a quick overview, now I have to be really quick, is that
So it's Project Rose, Realizing Opportunities for Self-Empowerment, based on self-determination theory, and we did screening in waiting rooms at 3 women's health practices targeting women living with poverty. And we did not focus just on pregnant women, so women, pregnant or not, who are coming to these women's health practices for any kind of care. They had to be 18 or older, they had to have elevated depression on the PHQ-9, and not need immediate risks or be getting current case management, and be English speaking. And then they were referred to randomized to one of 2 arms. One was enhanced because it's comparative effectiveness, so we had 2 active arms that they were randomized to. And they were either randomized to enhanced screening and referral, which meant that after they did their screening for eligibility, we asked a whole bunch of questions in different domains. They would get a referral list based on what they endorsed. So if they said they had problems using alcohol, we would give them recommendations about how to get alcohol treatment. If they said they didn't have access to a phone, they would get information about how they could work on that. And then they got check-in calls offered from our project coordinator to help them initiate those services, and check-in calls once a month. And then the Personalized Support for Progress arm, PSP, was working with mentors, which is what our team told us we should call community health workers. So, and so they would complete a problem sorter prioritization tool, which Elaine just mentioned, to identify the problems that were most important to them. I'll show that to you in a second. And then develop a personalized care plan to work on their prioritized problems. And then they got help implementing the plan. The idea being that just because you have elevated depression doesn't mean you want depression treatment or that you need depression treatment, and that by asking you what you feel like you need and what's most important to you, we might be able to help you address some of those priorities for you, and it might also create an opportunity to improve engagement for depression treatment by using that relationship as an opportunity to educate about how depression treatment might help. Yeah, go ahead.
The prioritization tool actually was developed a lot by a program called Baby Love. We had focus groups of the workers with Baby Love who actually gave us input on the things that they thought their different clients needed.
As well as women from the clinic,
yeah,
too.
From the clinic.
Yeah, we had focus groups with both community health workers working with pregnant women, as well as women who are receiving care from the clinic to get their input. So this is just a snapshot of the problem sorter, which is basically an electronic card sort, and these categories were what we generated with the input that Elaine just described. And women would say either biggest problem for me, not a less of a problem for me, not a problem for me, and then within biggest problem for me, we would the mentor would work with them to help them rank order within that category. And so they might decide that their mood is a problem for them, but they might decide that their healthy living habits are important to them, or getting their immediate needs are most important to them. And so this is a structured way, because we all know that experience of being so overwhelmed because you have a laundry list of different things that are going on. So it's a structured way of walking people through and helping them decide what is most important to them. And then they would create this plan. It's hard to read, so I won't walk you through it, but they would work on that with their mentor about what they actually wanted to do. And then our primary outcomes were satisfaction, depression on the PHQ-9, quality of life on the WHO, on the WHO, and when we assessed them 4 times, at baseline, immediately post-treatment, and then 3 and 6 months follow-up. We'll only be talking about the post-treatment outcomes here. And so the aims were to that patients would be more satisfied with the PSP, which is the mentorship intervention, than ESR, the enhanced screening and referral, that there'd be better outcomes for depression and quality of life. And then we had some subgroup hypotheses to try and identify who might really need that extra level of support from working with a mentor, compared to who might be fine just with a resource list alone and not need that personalized support. So we know, why did we do this? So first, there's the science reason. We know that reproductive age women are at both increased risk for poverty and depression. We know that most women have worse physical and mental health. We know that most of them aren't getting the care that they need and are getting missed or are under-engaged in care. So we've already been talking about that today, so I won't spend a lot of time on that. The WHO's social determinants of health model is a really important way to be thinking about how how do we approach not just the symptoms and the biological issues, but the social issues too, as part of thinking about how do we walk up to health. And then there's our community reasons, right? So Rochester is a beautiful city, and this gives you a sense of what it's not quite looking like this yet, but soon we really hope. We're getting closer, it's considered a really livable city, a city with a good quality of life. We have access to good public schools, nice job opportunities there, and so we're really proud of that. At the same time, Rochester, it's changing year by year, but is one of the poorest cities in the country, and we have an incredibly high poverty rate in the city. We have especially childhood poverty rate, and we have terrible infant mortality. If you look at national rankings for where our infant mortality is, we rank comparable to Croatia, which is 33rd in the world. So it's horrible, and of course it's worse if you're poor, it's worse if you're African American, it's worse if you're Latina, and so it's a problem. And so this really started as a conversation with multiple people kind of expressing frustration to Kate Cerulli, who's a research partner of mine, and I, about how they felt like their needs were not getting met, and that they felt like that providers didn't understand their experience, and that their needs were fragmented. Do you want to say more about that, Elaine?
Yeah, that is where the prioritization tool really was something that I didn't understand at first, but it came into focus when we realized that there were so many categories that we originally had, and then we were able to focus it down to smaller ones. And to me, personally, it made more sense, and it helped with the frustrations that not only the providers had, but that the patient had, because they couldn't communicate what their issues were, or at least effectively enough. And it left the providers with not the knowledge of how to help them, how to see them through their treatment.
You're raising a really important point that I've been talking about. Individuals with a lived experience being really frustrated, but as we learned along the way, providers were very frustrated and discouraged by not feeling like they knew how to help their patients too. And so there's really both those constituencies, which are really important to be thinking about. So we named ourselves the executive committee, but we didn't really start this way. There were 4 of us that decided to start having coffee every 2 weeks and talk about these issues together, right? And so there was a head of a local community organization, one of our stakeholders, Carly Wise and Kathy Mazzata, and then Kate Cerulli, who's the research partner I mentioned, and I just started talking. And at the beginning, we just started talking about what do we really even think we're talking about here? What are our shared experiences and concerns? Trying to build trust, trying to identify language that we were all comfortable with and come to terms with that. And then we just did this for a while, and then we got a little bit more formal about it because we decided to apply for seed funding. There were no engagement awards then, so we applied to the Department of Psychiatry, Office of Mental Health Promotion for some seed funding, and in order to do that, we had to define what it was that we were actually doing. So we developed a mission statement, we continued to try and develop our ways of talking with each other, and decided we were going to develop our own CAB, which we call the Collaborative Community Partnership. And so we spent a lot of time talking about the logistics. Where are we going to meet? When are we going to meet? How are we going to structure this? What's a reasonable ask of people? At that point, we didn't have money to pay people to come to the meetings. We were only applying to get enough money to provide dinner, and that was all we could really do, and materials. And so we each nominated people that we thought would be good to be on this panel. This is when Elaine got invited into the process. And we wrote a letter together that very clearly and explicitly defined what was it that we were asking people for. So we asked people to commit to 4 meetings over the course of a year, from 6 to 7:30 over dinner, to with dates in the letter to talk about these issues, and then to let us know if they'd like to sign up. And people were really excited and interested. So we were really happy about the response. And so we approached people with lived experience. We approached clinicians, a range of clinicians. We also approached people from like the local insurance company and other organizations that represented that arm of things. So this is the little model that we developed for ourselves about our partnership that included the community organization, the lived experience, and the University of Rochester to kind of come together and complete our community collaborative partnership, which now we just call CAB. So, like I said, I got ahead of myself. We agreed we'd meet 4 times, and these are the things that we talked about how we were going to do, it, and trying to decide what place would feel accessible and safe for everybody was critical too. So, on a bus line, handicap accessible. We actually tried a couple of different places that weren't quite right. Yeah. So we did some learning the hard way too. And included in this group were people who had personally experienced intimate partner violence. So thinking about issues of safety was really important, and how to make it feel as comfortable and welcoming for people as possible. And then once we got that pilot, then when we weren't paying ourselves for just, we paid for dinner ourselves, but once we got this pilot funding, we were able to actually pay people for participating, which I think is really important because it sends the message that your contribution is valued and matters, and you're not asking just to volunteer your time, but that money speaks. So, all right, go ahead.
Okay. So when we started the meetings, and we had, I think there was 12 people sitting at the table at the time. We had introductions, and we had set our goals, where we're trying to set our goals, and present the evidence. The resources and the barriers that existed in our community, what problems people were having, brainstorming solutions, and sometimes they were very loud brainstorms. Reviewing and revising the proposed model. We started out with a one-stop shop for victims of domestic violence. And we applied to PCORI, and that was denied. So we kind of pared it down because PCORI said it wasn't a wide enough base. I personally, being a survivor, took offense. But then when we got into the actual research, I realized that what we were trying to do was too big at the time. And so paring it down to depression, which is not paring down, but it was very, much wider, broader base than what we were originally starting. It helped a lot because we were able to develop the tools that we still use in our second PCORI grant, which is for a one-stop shop for domestic violence. So, the brainstorming, and we maintained, our CAB has been maintained and grown since our initial time around that table for the last 7 years. So, yeah, everybody having a stake at the table makes a huge difference.
So,
That's you.
I think this is me, not you?
No, it's you.
Okay.
I don't care, it's you anyway.
All right, so we tried to bring a spirit of respect and had all parties participate equally. So, and interestingly, what I didn't anticipate was actually there were 2 male physicians who were attending, and one was challenged, I'll say, by 3 of the patient stakeholders quite assertively. And so it was really interesting because I think that's not usually how this dynamic goes and not something that we had anticipated. And so I also think we were learning along the way about what did we need to do to make it as open and safe a place for everybody to communicate and feel heard and have their perspectives heard. And so I think we got better at that with time. Would you agree with that? Because that was really important, and that we can all respect that there are no right answers here, but that we're all bringing different points of view to the table. And related to that, we also learned how important it was to kind of prepare patient participants to think about what it might be like to share their story in a public way. How much of their story did they want to share? What is private? What is public? I mean, Elaine's now been on the radio for our public, I think it's 60,000 people for a call-in show, right? So you really want to anticipate what that's going to be like and know it ahead of time, instead of kind of have something tumbling out and then feel like I'm not really so sure that was the right thing to do. So we ended up learning that along the way too. So this one's yours.
I don't think I have that one.
Do you not have that one? You want me to do it?
Yeah,
okay. So recognition that all perspectives were invested in creating positive outcomes. Clinicians' knowledge was enhanced by the experience of stakeholders. Stakeholders gained greater understanding of care providers, creating and maintaining true integration to be a positive process where we were all really working together, and really wanting to have a comprehensive system. So what we did, and we'll show you in a second, was develop the model that everyone thought was the ideal model, and as Elaine said, was way too big to really do that. And then the researchers in the group kind of took a look at that and say, what slices do we think we can take of this to try and then apply to actually be funded as a place to start. So
that is me.
Okay.
All right. We brought together a range of stakeholders. We took, and what is that word? Indigenous query, and created a vibrant and rich process to investigate the question, the long-range impact and the benefit for the community, advancement of knowledge, and make sure this venture would be worthwhile for the effort. All right, no, the next one's mine. And the themes included the emphasis on safety, again, because we started out with the idea of being a one-stop shop for domestic violence. We were really concerned about safety. But even for just the depression, you still want to make sure they're safe. The importance of the provider's education, the need for integrated accessible care that addresses the needs and comprehensively and effectively. Focus on the outreach and the support to improve the access and engagement and the partnership between the patient and the providers. And I have to say that with the patients that we had that joined the research, they were definitely listened to, and they were their thoughts and their needs were more met than I think they would have been in just a regular clinic setting, because they sat with a mentor. Well, you guys, what'd you call him? Yeah, we called him a mentor. But the mentors were people that could relate to them and their needs, which was a big deal.
So here's the comprehensive model that we ended up developing, that the idea was supposed to be that it would help address women coming with complex comorbid concerns, including trauma, including chronic health problems like pain, including mood problems like depression, and that through this we were going to try and have an education arm to support providers working with patients, consultation for providers to be able to get help when they needed it, and then provide integrated clinic. So really trying to provide support on different levels, as well as a crisis line for patients, and the peer navigator, the mentor, community health worker who could go outside the confines of the office, and group support. So obviously this is beautiful, and everyone was excited about it, and a little ambitious in real life, but we decided to really focus on the patient care delivery part as a place to start.
Yeah, and the Community Advisory Board is really an important entity to all of this, because they actually see a lot more of the needs sometimes than we do as the stakeholders. Reviewing the existing resources and targeting the population. We did target a particular population. Review the literature, identify relevant outcomes, and boy, I got to tell you, we get in, still to this day, after all this time, we get into very heated discussions sometimes about what the relevant outcomes are or how they should work when we see them. And they selected and refined intervention approaches, and they chose the study site, and we did. And that was a long process, because we wanted it to be a safe place. We wanted it to be, we didn't know if it should be a medical facility or it should be what do we say, a town hall, school. We didn't really have a plan, but we came up with one. And we decided that it was going to be held in the women's health group. So it was some OBGYN practice. And a lot of the women there definitely are economically disadvantaged.
So we were trying to think of where would we be the most likely to find women who would already be going there, who could be, that we could gain access to and might be likely to keep coming. And that was how the group ultimately decided women's health settings would be a good place to go. So that's just one example of kind of the conversations that we had. So I already mentioned, we learned about creating ground rules, coming to the table as equals, that trying to bring everyone up to speed and learning about what does it mean to be involved with research, learning a little bit about methodology, human subjects, that kind of thing. We found that we needed to invite different people along the way. We would realize that we had gaps in terms of our representation and perspectives, and so it was fluid in terms of trying to recognize that. We also, when we got the funded trial, we created a national advisory board as part of the group that we had, which met less often, but really their key group was how can we think about dissemination on a national basis, not just in our immediate community, and that was really useful. So for example, we had a person who who edited a magazine for bipolar disorder and for depression, and had lived experience herself, who came and helped us think about how would we get it out to people who might be a readership of that magazine. So, and so that was interesting. And then continuing to revisit the basic tenets to say, how are we doing? What do we need to do? Creating space to check in, either by writing or phone check-ins, to see how people are finding their experience. So then to go back to the trial, so I already gave you an outline of ultimately the trial that resulted in, which was a comparative effectiveness trial. We ended up with 223 OBGYN patients who all had depression, and just about all had socioeconomic disadvantage. That wasn't eligibility criteria, but given the clinics that we were pulling from, that was generally the case. And they were randomized to one of the two arms that we described: enhanced screening and referral, or personalized support for progress. And then again, the aims were to see if there were differences between the groups for satisfaction, for depression, quality of life, and if there were groups that had particularly likely to respond if they received PSP, including those who had experienced trauma, healthcare barriers, low activation, and health problems, anxiety, to see if they made a difference. So in terms of basic demographics, so about 30% of the women were pregnant. You can see that most were lower income, most were single, and had, were of reproductive age, not surprisingly, and had young children at home with pretty poor overall health and high numbers of negative life events. So here's the first step where I felt like we saw some payoff on what we were doing. We had 76% of women who we were randomly screening with iPads in waiting rooms at these clinics, right? And 76% of the women who screened positive on that initial screening agreed to go through the assessment to see if they qualified for the study. So I think that's unusually high for this kind of setting, to have that kind of agreement. And then we had amazing retention. So we kept somewhere between 94 and 96% of the women all the way through the trial. And I think that is unusual too. So we felt really, really happy about that. And we have a paper under review about some of the recruitment and retention efforts that we did, because I think that's another whole story, because that was a lot of effort too from the team. with guidance from the CAB. So go ahead.
So both of our patients groups were highly satisfied. The example in the overall general sense, how satisfied are you with the services you received? Very satisfied, mostly satisfied, indifferent or mildly dissatisfied, or quite dissatisfied. And our PSP mean was 1.61, and our ESR mean was 1.71. And I have to say that I really feel that the reason, and they all scoff at me when I say this, but it's true, I think the real reason why we were able to maintain and retain so many people in the program was because they were called, they were checked on, they were validated for their feelings and their needs. And to me, that was huge. And I think that's really why we maintained so many people in the research, because they had a stake in it too.
So, and I don't think I said, this is the client satisfaction questionnaire, so in case you're wondering what measure that was. And then the depression results. So again, both groups showed statistically significant improvement for depression on the PHQ-9. So 14 to 10 more or less for the community health worker intervention, and 15 to 12.5 or so for the ESR. So we had improvements for depression for both groups. Now, of course, this meant we didn't get differences between the two groups, right? So we did not have group differences for any of our primary outcomes. So we found improvements on both sides, except for intimate partner violence as a subgroup. So women who came into the study endorsing on the Feldhaus that they were experiencing intimate partner violence, if they were assigned to the PSP intervention, were half as likely to experience intimate partner violence, which is kind of interesting, and I think related to the whole card sort intervention, right? Because we weren't recruiting for IPV, the intervention wasn't IPV focused. I think it's easy to call it trauma sensitive, right? But it really, unless someone said this is what I want to work on, it wasn't what we were targeting. But we found improvement there. And then we did have some nice subgroup differences for quality of life, that when we saw more improvement for the PSP group than the ESR group, for groups that in addition to depression and socioeconomic disadvantage had high chronic pain, had high anxiety, had recent intimate partner violence, and also reported lack of access to depression treatment. So either lack of, on Cooper's measure, lack of familiarity with how to get access to depression treatment.
Oh, okay.
So now what does the CAB do, now that we've got our data?
Yeah. Okay, the provider feedback on assessments identified the gaps in the rural and Spanish-speaking community is a big concern of ours, and we didn't seem to be able to, because we had it limited to Monroe County. Monroe County isn't necessarily a full rural county, but the outlying counties are extremely rural. And I was telling Ellen, one town that I lived in when I was growing up, we had a bar, a gas station, and a grocery store, and that was it, and we didn't have anything else. So the access to provider care, you had to go 15 miles into the city, Batavia, to get any kind of care. So rural concerns are still there, and they were amongst the members of the advisory board. Addressing the challenges with recruitment and retention, and we talked about that a lot. Interpretation of results. I'm sorry, my eyes are really bad. Dissemination of the findings. Some of the members of the advisory board have actually written papers on the results and on the progress.
Including you?
Yes, including me. And we define next steps, which we have now our HEAL program, which is our one-stop shop for domestic inter-partner violence. And it's been a learning experience that I've loved.
So here you're already
and
starting.
Here I am. I'm a member of the patient leadership team for the HEAL program, and I was an involved member of the advisory board for the ROSE program, and a patient, what did you call me? They have a name for me.
Patient leadership team.
No, not that. When I was on the ROSE project, we had a name.
Patient partner.
Patient partner. They always change it. Anyway, and so our patient leadership team has actually seen some great growth. We have one of our members who went and got her master's in business while she's been working with the team. And for her thesis, for the end of her degree, she did a project for us, and it's called the Simon School Project, but it was to try to find funding or a way to at least convince the hospital that the HEAL program can be sustainable. So we're still working on that. Education degrees by the stakeholders. We have two of our mentors. The one mentor now has her master's in social work, and the other one is going to be receiving her master's in social work. Sustainable team, I told you, our team has been not only sustainable, but has grown. I think we've lost maybe 4 members, and over 7 years, that's pretty good. The role of dissemination in the community, I don't know how to put that. Because we have so many so many people on the advisory board that belong to the community in different varying ways, the dissemination has actually been widespread, I think. Satisfaction and fun? Oh yeah, obviously. You can't go anywhere with me and I don't have fun. Okay. Additional projects include our second PCORI trial, which is the HEAL program. And my last thing is personal importance of the community involved in research. For the participation of a stakeholder, I got to tell you, being involved in this was such a big deal for me. My background was the reason why I came to them or was introduced to them was because I was a survivor of domestic violence. But I'm also a survivor of, I carried a baby to term and she lived for 45 minutes. I didn't know I was depressed. I thought because I went to school and I took care of my kids and I cooked a dinner, I was fine. And it took me 3 years of not being fine. But the only thing they really gave me was medication that I couldn't take. And eventually I found a counselor, but it took me, I think, 4 counselors to find one that would actually sit with me and talk with me about what I was going through. And so to me, this is really important. You guys have to make this work because there's too many of us out there. Okay. You gotta finish.
Yeah, I can't go after that. So, and we still have some Q&A time. So
Oh, do we? Oh, God.
I
think we did this good.
So I would like to suggest that this means we have more useful and better quality research studies that we all learn and grow together. I think that I'm a better person and a better researcher as a result of this work, and it's really exciting for me to watch my colleagues grow through this process too, and that it allows us to do real life work that hopefully improves care delivery and patient health. So we tried to leave some time for Q&A, which it looks like despite technical difficulties we managed to do.
Minutes.
So yeah.
Okay.
Thank you so much. That was wonderful, and it feels like I paid you to say this.
I know, I thought you stole from us, actually.
But to see it actually working in the real world, right? We live in our ivory tower at PCORI, and we talk about what to do, but you guys are actually out experiencing it. So you talked about how you all spent 7 years forming this partnership, so the fact that it takes time. Can you talk a little bit about some of the challenges that you faced and maybe how you overcame them? Because you've been talking, it's all roses and wonderful,
Yeah.
but I'm sure there were some tough
Yeah.
things that you had to work through that you would be able to benefit.
Yeah, I was thinking as I was sitting here today, we should have included some slides specifically about that. But do you want to go first?
No, you go ahead. You really want to hear what I have to say. They do.
I think that yes, you're hearing the successes, but there have been many challenges. I think that I'll start with the flip side of how long this takes, right? So I think that with the kind of infrastructure that PCORI now has in place, and there's more of a map about how to do this, people can probably do it more efficiently than we did, but we were really creating the map as we went. My colleague likes to say, building the plane while it's in the air, and we didn't really know what we were doing. And so I think that there were a lot of it was slow going, and we had to kind of sometimes step back and think about what are the right ways to do this. So I think that was sometimes challenging. And I think also related to that, what you could hear Elaine talking a little bit about too, is framing what is our question going to be, and trying to get everybody on the same page about a question isn't easy to do, right? Because everyone has different ideas about what that's going to look like. And so kind of doing that balance of really wanting to have consensus and have everyone's voice heard, and at some point deciding it's time to make a decision and we have to move forward, balancing wanting to be respectful of everybody's input, and this is what we think can and can't get paid for. I think that always felt challenging. And I think also, I think comparative effectiveness research is challenging, and that what you can see is that now we don't have a hit it out of the ballpark outcomes trial. And so because we don't have the primary outcomes. And in fact, we applied to PCORI to get a dissemination and implementation funding to extend the results, and they really liked the proposal, and it was well received, and then they decided our outcomes weren't strong enough to support it. So we didn't get to continue to move forward. So we were really excited to take this and broadly disseminate it again with community health workers and see how that went, to having them to deliver it, and we didn't get the funding to do it. So I think that has been a challenge too, to figure out how do you balance that, taking real life research that has all of that messiness, and working within kind of the funding streams to convince them that what we're doing is rigorous enough and clean enough to keep going. I think those would be my main themes. Maybe a little too transparent, but. Did you want to say yours first?
No, we can go with that.
Are you sure?
Yeah, sure. You guys heard it all before.
Yes. We haven't heard it.
Tell you in a minute. Yes, Megan?
So one of our biggest challenges, I think, on our patient advisory board has been clarity of communication between the researchers and the patients, and helping everyone get on the same page, because we all come from so many different backgrounds and education perspectives, and things that seem super clear to a researcher, for someone who doesn't have the background in academia, it's like, I have no idea what you're talking about right now. So what did you guys do?
Gotcha. Yep. First of all, we have a rule at our advisory board. You know the rule. Okay. No acronyms. Not one. You got to give it all out, and you got to know what you're talking about. Okay? Second thing, for the people that aren't the academia, speak up. Your voice is valued. It really is. If it wasn't, they wouldn't have invited you there in the first place. If you don't understand something they're saying, tell them stop. Please let me understand. Explain it better. And if they start using medical terminology, make them stop. I was a nurse, and I can tell you, I used to hear all that medical jargon, and thank God I understood it. But they would be angry with me if I didn't use it with the patients. And it's like, seriously? I hardly understand this stuff. I'm supposed to explain it to them? So to me, it was always the important part. That was the challenge, was getting the courage to sit there and say, stop. Okay? And not only say stop, but not feel intimidated because, you know, I was an LPN. These guys are all doctors. I was a little intimidated. But I got to the point where I wasn't anymore. And you really, once you start saying, your voice starts being heard, and you start saying, wait a minute, what does that mean? And like I said, no acronyms. That is our absolute rule, and believe you me, some of those acronyms, they need to be there, because the words are awful. And she was talking about the challenge, okay? One of the challenges was this. We had a whiteboard that was as long as that, okay? Not up there, but long. It was full of all of our ideas. So you gotta know, it was tough paring it down because everybody had a voice and everybody spoke. And it's so important because if you don't speak up, you're gonna lose interest. And you, the patient, is the most important, well, not the most important, but equally important part of the advisory board.
I have a couple other things to add. I have a colleague who, as she was doing stakeholder research, did something I really wished I had done, which was basically develop a course to introduce research concepts and bring everybody along. And I think if we had thought of that, that would have been really excellent, right? And I think related to that, I think institutionally we need help with helping people get human subjects approval too. I think that if we really want all people to be able to participate in research, getting through the Belmont report and getting through that exam is really demanding. And we have at least one person on our team who just opted out of that, who I really would have liked to have been able to participate in data. And you know, the right thing to do would have been for me to sit down with this person and walk them through it and help them, you know, do that tutoring. And I didn't. And so. Right. There's only so many hours in a day, but I think that's probably just my one example where I think I'm guessing that is a common challenge that I don't think is well, that we've responded well to yet either.
You got 5 more minutes. Yes.
I was wondering if you could say more, because you mentioned recruitment as being an important piece and that maybe evolved with the input that you were getting. And I wondered if you could say more about that, and especially how it changed your approach to recruitment as you moved.
Very concretely. So I think, first of all, we got input about who we should hire to be our recruiters, and what kind of characteristics were important in those folks. We also got input on a script that we wrote for the recruiters to use. We shared the actual screening tool, and we were told it was too long and complicated, and we pared it back. I also think related to stakeholder engagement, we spent a lot of time partnering with these practices and the staff and clinicians who worked there. We did in-services about what the study was about, why we were doing it, why we thought it mattered, why their role was important in helping be able to do this. We went back and presented the results with cookies, because I think that was really important too, because we wanted them to feel like they were a part of it. Can you think of other things?
Well, I think the biggest thing was the fact that they were able to sit waiting, they were able to do something with their hands while they were waiting to see the doctor. You know how you go in the doctor's office, and even though you're 15 minutes early, they're 25 minutes late. It gave them time, you know, they had time on their hands, and I think that was a big deal, you know, and the recruiters sat with them and helped them through the process if they had any questions. You know, so it was really a very personal, hands-on research. Everybody had their hands in it, and they weren't rushed. If they couldn't finish it, they could always do it later, or they could take it back with them. You know, I mean, it was just very comfortable. And I think if you make your what do you call them, participants comfortable with your research, that they're going to participate. I mean, we didn't really give much as far as an incentive.
No, for the screening, we gave pens or lotion samples.
Yeah,
little,
I mean, yeah,
little things like
really,
that.
you know, it wasn't like they were getting a $25 gift card to Wegmans, you know? And so, I mean...
Oh, we had chocolates, and the dietitian said, no, no, no.
Yeah. Oh, yeah.
So the chocolates went away.
Yeah, well, you know, there were a lot of pregnant women in that room. Anyway, and, yeah, but I think the comfortness that they felt was a huge part of it. And I think, too, we picked recruiters that were, they were empathized, you know, I mean, you could see them in your role. As a patient, you could look at them and say, oh yeah, they know, you know, they know. And that, I think, is an important part of it. They were approachable. And that, to me, is huge, because, you know, there's a lot of people out there that aren't. Anything else?
Quick question. Can you go back to slide 14?
Oh, God.
I can try.
Their number.
We're asking a lot of
guarantees.
Because you had some really interesting information on there that I was starting to take notes and forgot to write. Okay. Were these how you drove your needs?
You mean in the prioritization tool? Or which needs are you asking about?
When you were doing your needs evaluation,
Yeah.
and you described the people getting together in your coffee and
Yeah.
just brainstorming, what do we need to do? We obviously know that there's something wrong. This population is struggling. Are these the tools that you use to
Yeah.
discover?
Yeah, so no, so that's a good question. So we talked about, let me make sure I understand what you're asking. We talked about general domains. So what kinds of things matter to you? And what do you hope is gonna change? And so the quality of life really came from trying to figure out how do we get a global response to all the ways in which people are wanting to notice that they are doing better overall, and that they really want, you know, that was the primary thing that they were really interested in having us reflect. But we did not have our CAB choose the measures. So we had them help us choose the domains, and then the researchers went back and selected the measures that we thought would be best to reflect the domains that they helped us identify. Am I answering your question?
Okay, and initially, the 4 people that sat around that table drinking coffee, one was a survivor of domestic violence, the other one was the director of the program that we had locally, and then the other is Dr. Cerulli and Dr. Poleshuck. So I think that was how first we came to the realization of what was needed, more so than what was going to be used eventually. And that PHQ-9, that's her baby. That's how she measures depression.
Yeah.
Where'd you guys get mentors from? Who were they?
Good question. So we had two mentors, and what we were really hoping to recruit from, and what we ended up with, were women of reproductive age who were from the same communities as the patients from the clinics that we were serving, who either had personal experience with depression personally or in their family. And so both of the women that we hired brought all of those things to the table. Sure. Yeah, thank you.
She can start.
Yes, thanks for your patience with our awkwardness there.
Good morning, everybody. Good morning, everybody. Thank you. Welcome back to the second day of the symposium. Did anyone see the fireworks last night around campus? Anyone? So Ruby saw it? And Brandon saw it, I saw it too, and we have nothing to do with it. But it was nice, nice weather, and I hope you had a good time last night, enjoying the town for those of you who are coming from outside the Champaign-Urbana. So I'm in charge of the first 5 minutes of today's symposium. So on this slide, you can see the statue. That's the famous alma mater. So if you have time, you want to see her, then it's on the Green Street, and it's nearby the Union Building. We usually will put cap and gown on her this week, but this morning I checked the webcam. She's still maintaining her original, but you know, it's something to look for. It's a nice area to visit. Green Street also nearby, a lot of eateries. If you like, do we still have McDonald's there? Yes, I think we still have McDonald's there. Also Panera, something healthy if you're interested in that. Okay, so my responsibility is to welcome you back to the second day of the symposium. My name is David Huang. I'm the co-lead with Karen and Brandon on this particular project funded by PCORI. I'm from the Department of Education Policy, Organization, and Leadership. I also have an appointment in educational psychology. Some people asked me yesterday what I do in terms of this project. I have to think about it. So I probably will have time to talk about it later today. So recap. So we heard from the PCORI officer in terms of what PCORI does and what kind of projects they're willing to fund. It's very informational, and I think we all are very encouraged to submit our ideas to see if we can get resources for this community-based and patient-driven activities going. We also heard from speakers in terms of the mindful approach, in terms of the national policy analysis, in terms of the case studies on the comparative effectiveness trial from Rochester. So a lot of information yesterday. I hope you had time to somehow digest and trying to figure out which part of the information you would like to transfer to your future work better. So today we still have a very packed agenda, and we have speakers coming in to talk more, to share a little bit more about their experiences in terms of organizing the board and identifying the research approaches. We also will have a workshop, hands-on learning experiences for everybody to participate and to share and to hopefully to spark new ideas based on our interactions with our peers in this symposium today. Very briefly, to share I have to do this, I'm sorry. It's May the 4th. The force is very strong as everywhere in terms of PCORI, in terms of improving mental health care policies and practice and research in our communities. And I very much appreciate the opportunity to be on the project with my colleagues, and my perspectives including this is a very innovative effort. And we are all innovators in this room. We're trying to improve the quality of life for our peers, for our community members, for people we love dearly. So innovators in the room, and according to the diffusion and innovation model, we are early adopters, so it only counts for 15% of the entire population. So we're very special. I need you to know that. It's also about change management, how to identify processes and policies to scaffold the change process. We're trying to improve the quality. In this case, will be mental health care for perinatal women in the communities. And policies are not easy to change since we are collectively community members trying to raise our concerns and to our organization. Organizations are dinosaurs. They move very slowly, but they move. They do move. So I think it's very important to have persistent effort and a very eclectic collection of expertise to keep our ideas going. So I study motivations and engagement in terms of educational activities. And I think the engagement is different from motivation. In particular, engagement requires structures and achievable goals for participants to go after. We all need to have something to do to get the ideas going. Otherwise, we'll be watching Netflix every day. I think it's also a good context for us to think about the difference between practice and research. In this particular project, I don't see too much difference. I see we are at a very good balance between the two, and I also see practice and research should be connected and informing each other all the way. Evolutionary versus revolutionary really depends on what your philosophies might be when it comes to change. You wanted to take this slow, or you want to start from scratch all of a sudden. So again, this is the A versus B, and some ideas I have reflected upon since I participated in the activity 2 years ago. The next one will be the localizability versus generalizability. From the perspective of social science in general, I think we like to be able to replicate studies from places to places. In the context of PCORI project, however, I also would like to encourage us to think about how we can localize national findings, federal findings to our local community, because I think that's the best way to create impact, and I think that's the even better way to sustain the change you would like to see to happen in the community. Finally, I'd like to get technical a little bit, qualitative versus quantitative versus mixed method. 3 different ways of seeing data sources and how to approach data analysis. I was trained as a quantitative person. I have an engineering background. You cannot get more quantitative than that. But over the years, participating in different types of social science research and PCORI project, I think it's very important to recognize the value of the qualitative input. So a good analogy would be quantitative input, you know what's happening, they give you a rating, and qualitative input, they will give you the reason. And in the context of this project, I think we need both, again, to inform our stakeholders and to encourage our legislators to change the policies and therefore to, again, attain the improvement of the quality of our lives. So this very brief discussion, and again, I want to emphasize the force is very strong in this room, and it's going to continue to be very strong throughout the symposium. Without further ado, I'd like to introduce the next speakers. Will be Dr. Kelli Ryckman and Dr. Karen Tabb for their talk. Thank you.
There it is. See if I can figure that out. Okay, great. Thank you. So I'd like to thank Karen and everyone here for organizing this. I'm very excited to be here and talk to you a little bit about my research and sort of why I got into this, this field and why I'm really interested in patient-engaged research. So a couple of years ago, I was feeling sort of stuck. Like I was in the biomedical research field and I was doing all these biomarkers with genetic studies and it was great, but I felt like there was a piece missing to that. And I didn't feel like I had enough people at the table or the right people at the table. And my college at the time put out a call for individuals that were interested in building collaboratives around some kind of topic. And the topic that was really important to me as a mom who gave birth to preterm twins was preterm birth. So 1 in 10 babies is born preterm, and there's a lot of lifelong complications that follow that. And so I wanted to identify people that could come and sit at the table with me, where we could talk about our research and kind of figure out where we wanted to go and how we wanted to build infrastructure or resources at the University of Iowa around this topic. So I first started talking to people in neonatology, developmental and behavioral pediatrics, OB-GYN, you know, all the people that you would think you would talk to if you're studying preterm birth. Brought some of my molecular biologists and geneticist friends because I didn't want to leave them, and sort of built this team. But the thing that I recognized that I had no experience in and that I didn't have as part of that team were patients and caregivers. And that's a really important piece to really making and translating this research from the bench to the bedside, which was something that was important for us to do. So I put in a proposal for the collaborative to my college. It was a small startup seed grant. I also got foundation support as well to build this network where I wanted to combine the resources that we were already developing, so data resources. We were amassing these large cohorts of electronic medical record data and administrative claims data with the biobank that we were running. So we were enrolling families in the neonatal intensive care unit and collecting saliva specimens. I wanted to merge those with really this family and community engagement piece. And so I put the proposal in to do this with really the goal of us being able to think about multidisciplinary innovative science as a team to put together good research, particularly around preterm and low birth weight. At the time, I had met Karen kind of through kismet of being at a conference together 3 years prior, and then we, you know, talked to each other, said, oh, your science is cool, and then kind of went our separate ways. And then a couple years later, I had a very talented grad student join my lab who really wanted to study maternal depression, and I really didn't have that background. And I happened to be at the same conference again online, and I saw Karen's talk, and I thought, oh, I remember her. She's awesome. I'm going to contact her. And so I just emailed her out of the blue and got her connected with my grad students so they could think about maternal depression. And it just happened that I was developing this collaborative at right about that time, and as I was Googling Karen to get her contact information, I saw about the IDEA Coalition. And so I asked her, you know, what does this entail? How do I get on board with doing this kind of research? So to tell you a little bit about the 3 pillars that we've put together, one is, as I mentioned, our neonatal and pediatric biobank, and this started back in 1999, and we really focus on collecting saliva samples from moms and babies and dads where the baby's born less than 32 weeks gestation. And we have, right now, these numbers are a little old, we have closer to 2,500 families from Iowa, and then we have families from all over the world as well. And we've pulled this into some cool studies on the genetics of preterm birth, and I'm not going to bore you with all the genetic sort of background or science behind this, but I am very proud of this publication down here. It takes a village really to find genetic associations with these complex diseases. You can't have 100 samples or 1,000 samples. You have to have 100,000 samples. And so we joined a collaborative, a coalition, where samples from Iowa and samples from all over the world that we collected were part of this. And it was actually published in the New England Journal of Medicine a couple years ago as the first genetic association with preterm birth. And so we think we've now found a couple of really good targets where we can start to look at biomarkers and potentially look at some drug targets for prevention. So we were really proud of that. The next little piece I want to talk about is our data sources that we put together. So just briefly, we're also trying to come at this from a quantitative perspective. So David talked about quantitative versus qualitative and community engagement. Our quantitative piece include these really large data sources. One is built around the electronic health record at the University of Iowa. So we've created a database that includes over 27,000 deliveries where we can look at causes of preterm birth and also look at other things like maternal depression and how that's impacted pregnancy outcomes. And we have access to a second source as well that's insurance claims data, where again we have over 25,000 mom-baby pairs from our community that we can look at. And right now we've been using these data sources to study a wide variety of maternal child health outcomes. So the very wonderful student I mentioned, Nicole Knighty, will be talking about opioid prescribing patterns in postpartum women very shortly, like in the next 2 talks maybe. And we've also been looking at ADHD and preterm babies, and then also this perinatal mental health. So really to get to the goods of why I'm interested in PCORI research is this family and community engagement. So this pillar that I had proposed to my collaborative was to engage families in research initiatives by providing and promoting our existing resources, by identifying the research gaps and areas of interest, and then really putting together a resource for other researchers to come to the table and have access to family ideas and also have access to patients. And we're hoping that this will provide an easier platform for conducting patient-centered and community-engaged research initiatives, particularly in maternal child health at Iowa. So a couple of things that we've done on this in the last year is we put out 2 surveys. So we had a researcher and public health professional survey, which is always important to get ideas from the clinicians and from public health practitioners that are practicing in the community. We had 131 responses, which I thought was pretty good for clinicians and providers. And really they identified that developmental and behavioral outcomes and access to these types of large data were the most important to them to be able to get access to, and also to get access to patient registries were identified as their top priority. We also put out a family survey, and we did this at different STEM events and at different fairs across the state. So we went to the Iowa State Fair and other places and asked 60 questions that were related to research and also just general health and pregnancy and maternal child health. And we received almost 300 responses, which I was also very excited about. And the thing that I found very interesting here was about 93% of our participants that completed the survey really wanted to continue participating in research initiatives around maternal child health. So we have a very engaged population that's interested in this research and wants to continue with us. I have to show some pictures because otherwise slides are just boring. So this is us at the Iowa State Fair, and by us I mean that table over there. And they have also been at a lot of other events, including local March of Dimes events and different community fairs. My favorite picture was orchestrated by Nicole, where we got Herky, which is the Iowa mascot, the University of Iowa mascot, to stand by our IPHRC banner, which was very important to us to have that picture. That's like gold. You can't get that for free. So we were excited about that. The other thing that we did was establish a website, a Facebook page, and our community advisory board. And I'm so grateful to have my community advisory board members, some of them here today, so Lori and Sarah that you'll hear from later. And we had Suzanne and Leslie yesterday that spoke as part of the panel. So I'm very happy that they were willing to come on this journey with me and sort of figure this out. As I mentioned, we were established in October of 2018, so we're really new. So as we're sitting in the audience, we're trying to learn from you guys on best practices and how we do this and how we function. We've had 2 meetings so far, so again, really new to this whole thing. But I think we're excited to continue this and to try to work together. And then lastly, this, I'm not going to play the video, but the College of Public Health was really interested in what I put together and just how we built these resources. And so they put together a short video on our research and sort of blasted it out to the social media universe. And my board was involved in that as well. Sarah gave some quotes for that and others. So we've been very proud of this work and we're excited to continue. We're still super new, but we're happy to be here and we're happy to talk to you guys. That's it. Now it's Karen's turn.
Oh, okay. Another run at Iowa. All right, so that's idea. Our two just stood up. I'll quickly tell you the background of how we got to where we are as a coalition. I am a professor of social work. I do research on social problems, social determinants of health, and how they manifest in clinic settings. Important to a small group of people. The work that we do captures the extent of problems, and we track diseases and disorders in clinics and highlight how bad or how good things actually are. We use studies called registries, where we collect electronic medical records or sometimes paper medical records for public health before they're fully implemented to track those problems. We look at things called disparities, so that's differences in group outcomes, okay? So disparities by race, income, place, ethnicity. And we've done a lot of work on issues related to mortality. As you know, the US is in a maternal mortality crisis right now, and I work on another team where we document that crisis of how bad things actually are. Our research, at most, goes to providers who use that information to make informed decisions about the care that they deliver, like how to screen women for care, how to screen for things like depression and improve women's care. We live in a state where depression screening, one of our major topics, is mandated. So all providers must screen for depression. We were the second state in the country to do this. Now there's 5 states. So California just came on board, so maybe now things will shift because they're so large. We just need Texas, California, New York, and then we'll be national. But what's interesting about our state is our mandate came out in 2008, long before those policy recommendations that you saw Dr. Zivin present yesterday. So when I moved here in 2012, I wanted to know what providers were doing in response to the policy mandate. We conducted interviews at Public Health. We met with public health providers that see pregnant and postpartum women to learn more about what they did to help them once they had identified women in need for support, referral, treatment, and follow-up for depressive symptoms. This work, it's old now, but it really sets the stage for why we're in this room. What we learned from providers is they didn't know how to screen, who to screen, when to screen, and what to do with those positive screens. For public health, they said, you know, we like this research with you. I'm looking at Brandon. Let's do more of it. So we built registries and put those in place. But again, researchers collecting data, talking to at most clinicians, providers, and that was the extent of it. We started talking about who's missing, which voices are not in the room, and at a point of getting tired. So you do this work, you write up an academic paper, 10 people read it, and so what? There's a 20-year translation gap from a paper actually changing practice. So at the same time that we were working on this, we were being approached by some really outstanding patients. I think this is what happens when you're in a university town. One of the first women, we have large registries at Carl where we have data on over 20,000 people. A patient says, you know, I have bipolar disorder. No one discussed this with me. How can I get involved in your projects and make sure this doesn't happen again? And we're like, oh, that's nice. But again, as far as we went at that time was talking to providers, not including patients. Well, the 3 of us, David, Brandon, and myself, so representing the College of Education, Public Health, and Social Work, decided to be strange and apply to a proposal that solicited patient input in improving research outcomes. We won. So we won this funding in 2017, and for the first time, we could describe our group, the IDEA research team, as a group of patients, providers, researchers, and administrators coming together to address the topic of maternal mental health and improve clinical outcomes. Our funder, as you guys now know, after 2 days of being here, is PCORI. And just to reiterate, this is money that was set aside as part of PPACA or Obamacare. And the key thing about this is that patients must be central from the very beginning of a research idea through the completion of the project. And people do this in a variety of ways on PCORI projects. You'll see a lot of projects that have executive directors of like the Lymphoma Society. They're like, we have patient voice. Okay. For us, we wanted more than that. We wanted real people. Our original funding was a P2P award. So that meant that we had a pipeline to a proposal, 5 years support to build a board, increase engagement in the community, come up with research questions, and then embark on a research proposal. 1 month into our funding, PCORI ended the program. So we didn't stop. We kept moving with a 5-year trajectory. We completed the first year. We were funded from 2017 to 2018 to build a community of people that are interested in CER. I know that's an acronym, but I'm going to talk a lot about CER in the next 5 minutes or so. So to build a community of people who are interested in comparative and effectiveness research. And then we said we're still going to go straight through to a proposal. And we've been plugging away ever since. Now, comparative effectiveness research means comparing two things, two options, two treatments, two approaches that take place in a usual care setting, okay? So when you go to a provider, maybe they say, would you like aspirin or would you like a cortisol shot, right? Two options. Which one works better? So we compare two different things, and we compare if it's effective or not. And we're going to have an exercise today at noon over lunch where we're going to get our hands dirty and see how tricky this is, comparing two things to see which is better than the other. To get to this, we need to work with patients and providers. It couldn't just be me, David, Brandon, sitting around the table again, writing up another paper, coming up with another study. So we put ourselves out there in a very awkward way. I'm an awkward academic, as you can tell. I wear weird clothes, and I'm not ashamed. It goes with the par, okay? But you have to put yourself out there and talk to real people in real places. So we started with a pregnancy expo. And there's a timeline at the bottom. So right when we got funded, we started with a pregnancy expo. The efforts at the time, because we didn't have a board, were led by our public health leadership team. So Sheila Rayla, Ruby Carpenter, Brandon Moline, David Huang, myself. And we put together an expo on a day where it was negative 30 degrees in Champaign, Urbana. And we're asking pregnant and postpartum women to come out to the library and get some information. Nearly 100 people came out. Okay? We asked people to participate in a town hall, again at the library, neutral ground, not the university, not the health clinic, free parking. People came out and talked about the barriers and facilitators for perinatal depression care in our community. It was awesome. We filled the room with white paper about what's working and what's not. Again, these are cold days, and people came out. We started having coffee hours. So the coffee hours are going to start in February of 2018. We held these coffee hours at Champaign Urbana Public Health District. We provided childcare so people could come talk while their kids played with toys, and parents could sit there and have a cup of coffee with the lid off, which is priceless. Okay, people really appreciate this. So we had coffee hours at Champaign Urbana Public Health District, and I say through now. We still hold monthly coffee hours the last Friday of every month at Big B Coffee. It's an activity we wanted to continue to support, and we never know who's going to come. Sometimes it's people coming in crisis, sometimes it's providers saying, how do I talk to more pregnant and postpartum women? But they've been wildly successful. I mentioned we had those early events in the community where at the library, and we had the town hall and the expo, and we started having coffee hours, and we solicited applications to the board. So would you like to participate in an advisory board for research? I don't know what sounds nerdier, but we received over 40 applications to the board. So our original board is pictured here. We had our first meeting at the end of February. We had a mix of patients, providers, researchers, and stakeholders, like administrators. And by patients, because PCORI always says patients, patients, patients. And I've been corrected by people saying, no, you're talking about women. They're not patients. Don't put them into the box. I can politely say, no, these are patients, because we're concerned with how people are engaged with the healthcare system, and we're not focused only on women. So pictured here, you see fathers, okay? We've had fathers say, why wasn't I screened for depression? Or why wasn't she screened sooner? I had to pick up the pieces. We have grandmothers on the board, said, I'm here because why was I the only person to notice that my daughter had an issue, right? So by patient, it's those that are affected and engaged with the healthcare system around perinatal depression screening. All right. From February 2018, because our funding was cut, they gave us 4 months to come up with a research idea. So how do you do that with a fresh group with a wide range of backgrounds, a wide range of interest, and I say, quite frankly, different language? We talk about the same things differently. We use this approach called PCOTS. Again, we'll be doing this on the exercise and lunch. So PCOT stands for Population, Intervention, Comparator, Outcomes, Timing, and Setting. So this is an extension of PICO, if you've ever heard that in a public health framework. People say, PICO, what's your PICO? Because it involves the timing of when this takes place, and then the setting. What is the usual care setting? This is something that must go on as a part of usual care to improve clinical outcomes. This framework was wildly helpful. Last night I'm looking at Megan. So Megan, one of our advisory board members and our project manager, said, we could have all the great questions in the world. When we came back to put it into the framework, it didn't fit, right? And then of those that did fit, did they match what PCORI wanted to fund, right? So this was our guiding framework to actually talk through ideas. Like ideas we had from the town hall. Some things were like providing support to homeless women, full wraparound support. Like, great idea, but how do we address that with research? And how does it fit into PCOTS, right? We had to work on a governance structure. So this is between April and May. We had to create a document by which we were going to operate as a group. Things like simple housekeeping and etiquette, that will come to meetings, that will participate, but then harder things. How do we make decisions? How do we vote? And we talked about this. How do we want all voices to be heard? How do we want dissent to happen? There's a picture of a training that we held, so a capacity building training that we held to learn more about different types of research that we could do. A picture of some of our engagement activities in the community, where several advisory board members participated in a color walk as a part of raising awareness around perinatal depression. And our board became larger. So we only wanted to start with 10 people in the beginning, but we had 14 people. And you know how hard it is to have a conversation with 14 people sitting at one table. Or can you even? I don't know. So we split the board into 3 groups: sustainability, engagement, and process. Some members said, I joined because I want to raise awareness about this topic. Sign me up for all the community events. I'll plan them. Let's do it. Others said, you know, I really like, this was a very small group, I really like grant writing. I like these activities. How can we go get more funds so we can do more? That's sustainability. And then process. How can we convey what we're doing to others? And what are those basic research method steps that we need? And that tended to be more heavy on the researcher and provider side as well. Around this time that we're doing these community events, there's also attention that we start to receive. We ended up partnering with the University of Iowa around May, June, thinking about how we can work together using the same type of data and what are the issues that we face across the central US that are similar. So partnering with University of Iowa, partnering with, again, Dr. Ryckman on the UCFF data project so we could look at factors related to disparities with larger numbers and keep that going to inform some of the work that we were doing. And along some point, NPR ran a story on our group, and it went to everyone across the state. We received a phone call from a company that had TMS technology. TMS is this device basically you put on your head, and it pokes you like a woodpecker 3,000 times every day for 30-some days, and it treats drug-resistant depression. The company said, we'd like to gift you a machine so you can start treating women in your community. We talked to the local healthcare system and said, we'd like to gift you space. If we can use this for research and bill it for clinical, we're open. We brought this idea back to the board, and it didn't fly. That wasn't our charge and something that we weren't interested in. So some of the things that happen when you're working in a group, as a health services researcher, I'm like, this is awesome. No one ever gives us gifts of technology. And bringing it back, it's like, nope, it's not who we are as a group as we start to develop our identity and our interest. And we let that one fall by the wayside for good reason. Going back to our topic, so obviously TMS is not our topic. We used that data from the town hall to decide where we were going as a starting point. What does the community think the issues are? What can we solve through research questions? The issue of working with a group to decide a topic is extremely complicated. And how do you do this? Do you have a debate? Do you vote? Do you sit there in abstention and say, well, I'll just wait for the next research project because I don't really like that one? We kind of did a combination of the first three by using a nominal group technique of reviewing the different themes, deciding on our top 5, and then voting on them. We're going to do this in the workshop today, so you can see how tricky this is, but it's actually quite fulfilling too. From these topics, from all these little sheets of paper and all these little opinions from the community, we actually came up with a research idea that fit inside the PCOTS framework, that was of interest of all of our advisory board members. They said, all right, that's good enough. It's good enough, let's do it. And we submitted a proposal. We asked for $3 million to look at the effectiveness of perinatal depression screening, how patients interact with that screen, what they do with information, and then how does perinatal depression screening during pregnancy impact birth outcomes? Very important. PCORI, the funder, said we're not buying all this mumbo jumbo about depression being related to birth outcomes. We don't want it. We're like, are you serious? As experts in the area, it's related. We need more evidence. We need more data. So we were rejected. But that didn't stop us. There's a tenacity in our group that I love so much. We said, well, they didn't want it. The only really main criticism they had was the birth outcomes piece. Let's delete everything about birth outcomes and just throw it back in, Hail Mary. And then we said, well, this time we'll only ask for $2 million. Less money, no birth outcomes, and they liked it. So we have a study right now that was invited, that's under review, to look at 2 things. Does screening during depression result in better outcomes during postpartum? We don't know. We honestly don't know in 2019. And then how does screening inform patients' experiences and their decision making? So when a patient fills out, in our state, a woman fills out a perinatal depression screen, what does she do with that information? And how does it help her move forward? I have a good feeling about this, that something's going to come out of this. And in this, our advisory board members are going to be interviewing other advisory board members. We're starting with patients interviewing patients, but we might expand to providers interviewing providers as well. And then the award that brought you here today, we were awarded in February by PCORI again, so a new grant, to conduct a similar series of activities to raise awareness about perinatal depression in our region, host the symposium, and host a film screening. So our next event is May 21st at the Champaign Library at 6 p.m. We'll be having a film screening on Black maternal mortality and preterm birth and a panel discussion. I hope you can join us then. I'm going to say we're just getting started. This is our advisory board now. So you saw us then, and now this is us now. We keep growing. We're all wearing our Idea Coalition shirts outside of the expo. It was a great event, and we're planning on continuing the work even next year. So I'd like to say thank you so much, and see if there's any questions. Maybe we could hold off for the break, unless there's one question. But so thank you, everyone. Thanks. Next, we have Dr. Charity Hoffman from the University of Michigan, who you're probably really interested in her talk on infant mental health. I know we are.
The talk title here doesn't match in the brochure,
okay.
Sorry, but it's the same talk.
Okay.
My talk in the brochure is treating the whole person, and so that is, thank you. That is what I want to talk to you a little bit about today, about a particular program. So I love that I'm following Dr. Tabb's talk because I work at the University of Michigan at Zero to Thrive, which is a research lab focused on early interventions for families. It used to be called Women's and Infants Mental Health, and like Dr. Tabb, we realize it's not just women that need this support. And so all the research points to the earlier you intervene with families, the better. When you see problems in early childhood, if you wait until the kid's a teenager, until they're an adult, it's often too late to make a big impact. And so the sooner that you can intervene to support young babies and children and their families, the better. And so I want to talk with you about a particular intervention that we're doing. In the interest of self-disclosure, I've really appreciated the vulnerability and the authenticity of the folks who've presented so far. So I will say I am not a mother yet. I realize that I tend to study the things I'm afraid of, so I interviewed about 80 strangers about marriage over a decade before I ever worked up the nerve to get married. And then for my dissertation at the University of Michigan, I interviewed about 50 first-time moms who had become a mother in the past year to ask about their experiences, their challenges, what was better than they expected, what was worse than they expected. And needless to say, the challenges are many, from financial to professional to interpersonal. And out of that research, I ended up getting a position at Zero to Thrive, where now I'm studying an intervention designed to support not just first-time moms, but moms across the period of becoming mothers, or for the first time, or mothers again. So the particular project I'm going to talk to you about today is a new program that they're piloting that embeds social workers trained in infant mental health in OB clinics. So we know that women often aren't getting the support they need, they're not getting the screening they need. And so there's this question of, well, how do we get it to them? And part of that is to start where they are, which is in the clinic. So I won't go too much into background because obviously we're all familiar with the interrelationship between depression, substance use, traumas from the past that then drive further self-treatment in any way people can, and depression. And so this cycle continues, right? And the question is, how do we interrupt that? Oh, this is a clicker, huh? So what happens when we don't treat perinatal mood disorders? The consequences are significant for both the mom, the baby, and of course the family as well. But we know that untreated mood disorders can result in poor nutrition and issues with weight gain, too much, too little, lack of follow-through on prenatal care, medical complications for both the mom and the baby, unhealthy coping strategies. When someone's not getting the support they need, they'll try to get it any way they can, and sometimes that's with drugs or alcohol. But just trying to convince someone to stop smoking or to stop using drugs when you don't address the issues behind it often are ineffective. And then once the baby comes, needless to say, there are challenges for the infant and for the relationship as well. So if mom is continuing to struggle and not getting the support she needs, it's hard to provide what the baby needs as well. And so this can result in consequences not only in the postpartum period, but in years to follow. So we talked about this a little bit at various talks, that so much of postpartum depression and anxiety and mood disorders go undiagnosed at all. They're not even screened, and when they are screened, they're not necessarily treated or treated adequately. And when they are treated, we still see problems with remission. So there's this huge population of women who are struggling and just not getting the support they need. And in fact, years ago, I was at a sociology conference, and there was a nurse talking about how at her OB clinic, they don't even want to offer a screener because they don't know what to do with it. And once you diagnose depression or mom tells you she's suicidal, now you have a liability and a legal responsibility to do something about it. So if you know you don't have the resources to treat and there's not much you feel like you can offer, it's almost better not to know. And so I really appreciate Dr. Tabb's project on how can we introduce screening into more clinics, but also how can we show if it's making a difference. And then we hope to go one step further and not just screen, but have a way to address it. So the question is how, right? We know the need is out there. We know that when it's untreated, the consequences are significant, but how do we reach these women? Oh, I'm going backwards now. So part of the idea behind this research is we need to start where they are. And where are pregnant women? They're at home and they're in clinics. And so this intervention is really meant to reach those women in those places. So we're working with a community partner called Starfish Family Services. They're based in Wayne County, Michigan. So that covers Detroit and a lot of the surrounding area. And it's informed by principles of infant mental health, which were developed by Selma Freiberg. She was a social work scholar at the University of Michigan back in the 70s. And she said, you know, it's not enough to just study adult psychology. Like, we need to look back at what happens early on in childhood. So when a baby doesn't get their needs met early on, when they don't have healthy attachment, that has implications for years to come. One small example of this, one of the women I interviewed about marriage years ago was in her 50s, had taken in a foster kid, and she said, you know, it's the weirdest thing. The foster kid was about 3 at the time, and she said when I first got her, she'd wake up from her nap, and I wouldn't know she was awake. This woman had raised 5 kids herself, and she said I wouldn't know she was awake because she never cried. So I would think it's been 3 hours, I guess she's still sleeping, and I'd finally peek in, and baby was in her crib, but just didn't cry because she had a mom who was a meth addict and learned, if I cry, no one's going to come for me. If I cry, mom gets upset. So the best thing I can do is to self-regulate and stay quiet because I don't want mom to get upset. So we know that even before a baby can cognitively process their emotions or know what they're thinking or communicate it, they're getting these internal messages from their caregivers, from their community, about what's a healthy response or what's best in their self-interest to stay alive. And so the core of infant mental health is early intervention matters, but also that early relationship matters. And whether that's with mom or grandma or a caregiver at a daycare center, that bond that gets established when young, where an adult mirrors to a baby their feelings, validates their feelings, responds to their needs, is so important. And when women are struggling with postpartum depression and anxiety and mood disorders, and just struggling to take care of themselves, it can be really hard to meet a baby's needs too. So what are the core components of infant mental health therapy? Infant mental health therapy is a particular modality that addresses all of these things. It takes into consideration both the baby and the caregiver. So it starts with building a warm, supportive relationship. So IMH clinicians have they're social workers, but have a special certification beyond that in infant mental health. And so key to it is not only providing tangible support, resources, referrals, but also building a relationship with the parent. And so often parents' unmet needs get translated into not being able to meet their kids' needs. You know, if mom's feeling isolated, mom's feeling lonely or sad or overwhelmed, then she can communicate that to her child. And so by the social worker being a calm presence, providing love, providing mirroring, providing validation, and saying, you know, it's okay that you feel this way, it's normal, lots of women feel this way, it can help create space for the mom to then hold her own emotions and hold her baby's emotions. Other components are developmental guidance, so helping moms know what's normal. You know, it's normal for a newborn to cry when they're hungry. It's normal for a toddler to kind of push back. It's not because they're a little devil or something, which some parents would say about their kids. It's because that's a normal developmental stage, that your 2-year-old's asserting independence. And then another important component of infant mental health therapy is reflective supervision. So helping the social workers themselves to process what's coming up, because often they might be triggered by, you know, working with a mom that they feel like really isn't extending compassion to her kids, or working with a mom that's struggling with substance use when the social worker's own mom might have struggled with substance abuse. So in addition to the social worker holding space for the mom so she can hold space for the baby, there's also reflective supervision built in so that the social worker gets support as well. And I'll explain a little bit later why that part is key. And then finally, of course, advocacy. So it's not enough to just work with an individual family, but to help think about at the policy level, at the system and societal level, what can we do to make sure that you know, something like screening becomes more commonplace and not the exception. So I mentioned Starfish Family Services. They have a team of infant mental health home visitors that they employ to go out into the community. And I think Michigan is unique in that there's a longstanding relationship with Medicaid and this infant mental health program. And so it's reimbursable by Medicaid. And I know that's not true in most states. But part of what allows this program to get funded is that Medicaid recognizes the importance of infant mental health training in social workers, and rather than just sending a bachelor's level social worker into home visiting, they will pay more to send an infant mental health trained clinician. So the question was, okay, we have this program, it does home visiting, we have other studies measuring the effectiveness of the home visiting, but how do we get women hooked into those services? How do we meet them early on and not wait until there's a crisis to offer services, but really let them know that this is out there as early as possible? And so part of the solution that Starfish came up with was, what if we embedded these clinicians in OB clinics? So women are already coming for primary care throughout their pregnancy. They have to be there routinely anyway. What if we kind of got them connected with the services at that point? So that's what we were brought on to study as a team at the University of Michigan, is this program working? Is it making a difference in the outcomes? So to say a bit more about the care, right, we know that standard of care is meeting women's physical health needs. So they'll monitor your infant's development and growth. They'll monitor your blood levels. They'll look for things like preeclampsia or signs of preterm labor. And that's normative care, is meeting women's physical health needs. But as you all are studying, right, what if we could also make sure that mental health screenings happened? That would be a next step. Then a further step would be, in response to those screenings, getting referrals, so that when someone does screen positive for depression on the PHQ, that we can make sure that they know where to go for help. We don't just leave them there and say, oh, you're depressed, and good luck. But then the fourth level, and this is what we're trying to study with this program, is what if we could have an infant mental health trained clinician there in the clinic that's ready to meet with them. So maybe when they're coming in, they're already meeting with the doctor and they start to cry, and the doctor says, I have 7 minutes with this woman because I have to get to my next patient. I don't have time for them to cry right now. What if they could call in a social worker right then, and that person could meet with them and listen to them and provide support or resources? I mean, sometimes they don't even need a solution, right? They just need someone to sit with them and say, it's okay to be feeling this way. So that's what we're trying to study, and we hope to try to make more normative in the future. So what does this program look like? Well, it starts with embedding them in the clinic, and it's not full-time. So as I said, the home visiting program is funded by Medicaid, who offers a reimbursement for each home visit. And so the reimbursement is significant enough that by having a caseload of 6 women, the behavioral health consultants can be freed up to spend some of their time in the clinic. So we're able to offer this service at no cost to the OB-GYN clinics. They're agreeing to have a person who's in the clinic who can meet with their patients, but they don't have to pay for it. So it's a good service for them. The newest stipulation, though, is they do have to let us come in and do research. So part of them agreeing to have this behavioral health consultant is letting the researchers find out, is the program effective? And by the way, there are only 2 acronyms I'll use. I'll try to avoid them, but IMH is infant mental health, and BHC is behavioral health consultant. So they specifically shy away from using the word social worker, and unfortunately it's because there's been such a stigma attached to social work in low-income communities that if you say, oh, the social worker is going to come in and talk to you, there's concern, is this person going to take my baby away? Did I do something bad? Are they going to report me? And so they really try not to use the word social worker, and they use the word behavioral health consultant. I'm trying to push them to use something a little more concise because I think it's a mouthful for a patient to say. And so when I ask the patients, like, oh, have you gotten any referrals? Have you met with anyone? They'll often say, yeah, some lady came in and gave me a referral, or I think it was the nurse or something told me I can get support. So they're working on branding still, and how do we communicate this service to patients in a way that they know where to go and who to ask for. So they're in the clinic part-time. Most of them are there 2 or 3 days a week, and then they're doing home visits the rest of the time. So their main role is to establish relationships with women, and it doesn't have to only be pregnant women, but a lot of their focus is on meeting women during pregnancy, and in the postpartum period, it's also sometimes meeting with women who had miscarriages, with infertility, women who've had sexual violence in their history, and things like that. So it's not only Medicaid patients, and it's not only pregnant women, but a lot of their focus is there. And the reason that in this study we focus on Medicaid patients is because the home visiting service is only reimbursable for Medicaid patients. And so in order for women to get the full range of services from in-clinic support to home visiting, they do have to be Medicaid eligible. But other women could meet with the behavioral health consultant in the clinic. So what we think this does is it offers a gateway to the home visiting services so that someone might not want a stranger to show up at their house and sit with them for 2 hours and know about what's going on behind closed doors, possibly reporting it. But they'll say, oh, Mary, I know her. I met her at the clinic. She's fine. Mary can come to my house. And in the case where a behavioral health consultant already has a full caseload, she can also refer to someone else on her team. So we call it a warm handoff, but she can hand the patient over to a social worker she knows and can vouch for, rather than just saying, here's a phone number, call this place, maybe they can have someone come see you. Another thing that we found having these clinicians in clinics can do is offer support for the medical staff, because as some of us have alluded to, doctors are often feeling overwhelmed and burdened and don't know how to address these needs and don't feel like their education necessarily prepared them for it, because they weren't taught what to do when a woman comes in crying because she just found out her partner's cheating on her and she has to move out of their place, but then she'll be homeless. So she has a choice, right? Do I continue to live with an unfaithful partner, or do I live on the streets? Do I continue to use drugs, or do I get off medication and then I maybe can't keep my kids because I can't care for them? So there's a lot of really difficult binds that patients find themselves in, and doctors and nurses don't always have the training to address them. What we're hearing at the clinics is the nurses, the front desk staff, right, they're all doing everything they can to try to support these moms, and they'll sometimes call a cab for a mom after her boyfriend abandons her at the clinic, or they'll try to call around for referrals and get support they need because they care and they want to do best by their patients. But how much better would it be if there's someone that's actually trained in the clinic that can offer that, rather than just people kind of defaulting and going above and beyond their job description because they don't know what else to do for their patients. So we are currently doing research at 10 different clinics in Wayne County. 8 of these clinics have a behavioral health consultant already, and 2 of them are control sites, meaning they have standard of care. In some clinics, that means there's a social worker that floats between 8 other clinics and is there 1/2 day a week. In some clinics, it means there's almost no access to services. But we are based in Ann Arbor, which is left of the map. It's not on the map. And so my colleague and I drive all over Wayne County to these clinics, and we meet with the moms in person. I can talk a little bit more about recruiting later, but we enroll in their first or second trimester. We meet with them again in their third trimester, and then we meet with them 3 times in the year after baby is born to kind of look at a range of measures of how they're doing and how baby is doing. So this question again, right, of intervention research, if we want to know something is working and we want to look at a comparison of what is it to have this program or to not have this program, it's hard to figure out what does it mean for the program to be working? What kind of measures can we look at that would quantify the difference it's making? And so our team spent a lot of time before we started doing the research, going back and forth with the residents, with the doctors and the clinics that we work with. And I don't think enough with the patients. I wasn't on board yet, but I'm inspired being at this conference to think about how can we include the patients more in the decision making. But ultimately, we kind of settled on 3 different levels of looking at the impact. The main one is the patient level. We're also looking at the provider level and the cost level. So can we show that this program is cost effective, that maybe it doesn't reduce costs, but maybe it also doesn't raise them? Because if a woman is less likely to have a preterm birth, if she's less likely to use the ER as a main source of medical care because she has a trusted person at the clinic she can go to, if she's less likely to have her baby taken away from her, end up in foster care or something because she's getting support she needs early on, can we make a claim about the cost effectiveness? So as I said, at the patient level, we're interviewing them at 5 time points. It's mostly quantitative questionnaire packets. And so we meet with them early in the pregnancy, in their 3rd trimester, and then 6 weeks, 6 months, and 12 months after baby is born. The recruitment criteria are the women have to be at least 15 years old, although so far, thankfully, everyone's been over 18 because there's a little bit more paperwork when they're minors. They have to be currently pregnant and receiving care at one of the clinics. They have to live in Wayne County with a couple exceptions, and they have to be eligible for Medicaid. And then some of the outcomes that we're looking at are self-reports of things like histories of childhood trauma. I don't know if anyone's familiar with the ACEs, the adverse childhood events, but it asks things like, were you a victim of physical abuse, of verbal abuse, of sexual abuse, of homelessness, or it kind of gives a count of traumas, and it helps to quantify, like someone that has an ACEs score of 8 has had a lot more early childhood obstacles than someone who had an ACEs score of 1. So we look at that. We look at measures like depression and anxiety, just asking women questions like, how have you been feeling in the past 2 weeks? Have you felt it all down and depressed? And we know that often there is a lot of stigma against mental health diagnoses. And so just last week I was interviewing a woman, and I kept getting at different ways of asking, have you been feeling down? And she would say, oh no, like I don't get like that. Like I don't get depressed. Or if I do, I just go to sleep. And actually that's a telltale sign of depression. But I could tell she was really kind of trying to skirt away, that like depression wasn't something she identified with. And so we try to have different ways of asking, okay, maybe you're not feeling depressed exactly, but you're feeling hopeless, or you're feeling like you're not interested in things you used to be interested in. So how can we kind of gauge where someone is and then look at change over time? And are things, do they seem to be getting better? Do they seem to be getting more improved if they're at a site where they're getting the support of a social worker than if they're at a site that they're not? And we're still pretty early in the research, so I can't tell you yet what the outcomes will be, but we're hopeful that there will be some indicators of improvement for the women. And then we're also getting feedback from the clinicians. So we're meeting with the behavioral health consultants themselves. We did a focus group with them, and we have regular check-in meetings with them and surveys at 3 time points. So we want to hear from the behavioral health consultants and then from the staff providers at the clinics as well. How do you see this working? Like, have you heard of the program? Are you using the program? Is it something that helps make your job easier? So from both the behavioral health consultants and the staff, we're gauging at the beginning, about 6 months in, and then a year down the road, is this a service that they find available to them and that they know how to use and are using? So to date, we have 95 women enrolled. This is actually huge progress, because if you had asked me 3 months ago, we had about 30 women enrolled. And I'll talk a little bit about the barriers, but a significant barrier was getting clinic buy-in, right? Trying to convince a clinic to let us come in, talk to your patients, call them at home, tell them about a study. And we do have patients occasionally say, how'd you get my name? And it's like, oh, the clinic gave it to us. So there was a lot of behind-the-scenes work that had to happen before we could come in and start collecting data. Of those 95 women, 28 have had their babies. So some of them we've already done the 6-week postpartum visit or even the 6-month visit. A lot of them are due this summer. And so we'll be continuing to collect data throughout the next year. And then from the surveys where we ask the clinicians, is this a program you use? Do you find it helps you to do your job better? About like over 3/4 did say yes, that they agree or strongly agree, or somewhat agree, that having this behavioral health consultant on site helps them to do their job better. A couple things that we've heard from them, there's a physician who's been at the clinic for 3 years who said it's always helpful to have more resources, that often the doctors ask the nurse to speak to the patient because, again, they don't necessarily feel like they're adequately prepared to talk to the patients. And so if they have someone on site that has the language and has the training to be able to meet with patients, it frees up the doctors from that burden of not quite knowing how to address it. We also heard from a nurse midwife who's been there over 20 years who said it's made compliance and referrals much more streamlined and accessible. It's a much needed resource that should be available in every office. And then finally, a clinic director I was meeting with, who oversees a number of the clinics in the region, said integrating a behavioral health component is definitely a provider satisfier. A significant part of their visit is about psychosocial issues. And it lengthens the visit. Doctors don't have the expertise to address this. And it's frustrating for them to feel like their patient walks away and they weren't really able to, even stop them from crying. Or again, how do you talk to a patient about compliance when they're busy fretting about how they're going to get food for their kids? So if they can help meet those needs, provide those resources, it makes it easier for the doctor to do what they're there to do. Challenges. So as we discussed yesterday a little bit, we can tell you the pretty picture of how great it works, and then of course behind the scenes there's always challenges. So again, a significant one is getting clinic buy-in, both to implement the behavioral health consultant program at all, and then to let researchers come in. But what we tend to hear is there's resistance up front, and people are not so sure, and like, do I have to pay for this, and is it really going to matter, and I don't have space. And then down the road they'll come back to us and say, how can we get more? Like, we want these at all our clinics. We want to provide this service everywhere. And so just last week, again, we had another clinic reach out and say, can you send someone? So I think once you get past the initial resistance, and as the clinics start to hear, and they're like, oh, well, they have someone, we want someone too. So there is a growing interest for this. Another challenge is getting the staff and providers to use it. So even if the clinic administrator agrees to have someone, what if the doctor says, look, I'm busy, I don't have time to learn a new thing, or I've been doing this for 40 years without a behavioral health consultant, I don't need it now. And so we've heard at some clinics there's a difference in buy-in, that some doctors are utilizing this program a lot, and they'll call the behavioral health consultant into every new patient visit, every OB intake visit, and just have them meet the patient. And others will only call them in if the patient looks depressed. Well, we know depression can look like a lot of different things, and so do you not call them in if someone's not crying? Well, I've talked with women who are smiling through the whole interview, and then the things they tell me, I'm like, you don't seem to be doing okay. But if they were never going to say that to the doctor, they would go undetected. As I said, there's a unique funding structure in Michigan, and so I do want to be upfront. Another barrier might be if other states wanted to implement this, that they don't necessarily have the funding structure in place, and so there would have to be creative thinking about other ways to meet the need, maybe to provide the clinician in a different capacity or to have the clinic help fund it. But that even though the program is great, obviously feasibility is a concern. And then we spent a significant amount of time trying to establish institutional agreements with all our partner sites. So my background is in sociology and social work. I thought social science IRBs were a pain. IRBs are institutional review boards. It's basically a panel of researchers and people from the community who oversee research to make sure that there aren't abuses of the public good, that patients aren't coerced into doing research or aren't manipulated or anything like that. And so I'm now working with 4 different institutional review boards at 4 different institutions to make sure that they all think our research is okay. And that's a lot of paperwork and a lot of time. And then behind the scenes, there's also agreements because we're looking at electronic medical records for our participants to track things like the number of visits they had, the diagnoses, the billing codes, that there was a lot of red tape. Hospitals have a duty to protect their patients' information. And so when researchers come in from a big university and say, hey, can we see all your patient data? They're like, wait a minute, no, like, we're not gonna let you in here. And so it took over a year to get into all the clinics that we're working with, to let them agree to let us look at their records. And then, of course, there are barriers for families to participate. So we're asking them to meet with us 5 times. They already have very full lives. I will say it helps that we're able to offer a financial incentive. And so I think even more than they'd show up for their doctor's appointments, they show up for the research visits because they get paid. So we have had a pretty high rate of retention, meaning women that start the study tend to stay in the study. So our next steps are to continue data collection, to continue to build relationships with our community partners. We're thinking of also doing a focus group with the sites that don't have a behavioral health consultant. So right now we're only doing focus groups with the behavioral health consultants themselves to ask them, how do the clinics use the service? What are the challenges? What's working well? But we don't have a formal focus group with the staff at sites without a BHC. And so we hear from them anecdotally, wow, we would love to have a service like this. Or just the other day, I had a patient in here, right, and they start telling you the story. And so we want to apply for additional funding in the next year grant to talk more with the clinics themselves. And again, sitting at this conference, I'm thinking we probably want to talk with the patients as well, because recently I was meeting with a woman, she had just had her 5th child. Her first 4 were all vaginal births that went really smoothly, and the last one ended up being a very traumatic preterm birth at 33 weeks following a lot of bleeding and emergency C-section. And she had significant PTSD that she didn't have going into the birth experience. And I asked her, have you met with the behavioral health consultant? Have you had a chance to talk with her? And she said, you know, if she were like you, where like I could just see her when I come into the clinic and I didn't have to make a visit, I would be happy to talk with her. But right now I'm so overwhelmed, I just can't make another visit. And so the challenge there is because the behavioral health consultant is only at the clinic a couple days a week, often if it doesn't line up with mom's schedule, they're still not meeting them. And so we hope down the road to make the case to Medicaid that really this should be a full-time part of the staff and not just someone who's there a couple days a week, but someone that should be fully integrated into the team. So that is it. Thank you. I'd be happy to take any questions. And here's about our funders. Yeah. Yep.
So you go into mainly OB clinics
Mm-hmm.
and focus.
Mm-hmm.
So was the actual title or, you know, the infant mental health part of it, did you find that automatically people were like, well, why aren't you talking to pediatricians? Why aren't you?
They do actually have some. They do have some at OB. At pediatric clinics as well.
But I'm saying,
but
does it throw them off thinking, well, this isn't about maternal, you know?
No one's asked me that. I don't know. But yeah, good point.
If that was like,
Yeah.
If they saw that and they're like, infant mental health, why would they?
Right.
Why wouldn't they? And what has that got to do with mom? And I
Yeah.
was wondering if that was a problem. And then the second part is there a certified body to become an infant mental health trained behavioral health consultant?
There is. And you can write to Zero to Thrive or to me, and we'd be happy to provide more information. Great, thank you. Other questions? Yeah.
So you mentioned when you do the assessments.
Mm-hmm.
How, if someone is screened in either postpartum or during their pregnancy and identify like, okay, this person could use some home visiting and some support. How often are the visits?
How often is the visit itself? So they're weekly, if it works for the patient. Sometimes patients will say, you know, that doesn't work for me, I want to do every other week. But the intervention is meant to be weekly, and it can be up till, I think, the child is 6 years old. So it can start in pregnancy, and yeah, it continues for quite a while. Yeah. Other questions? So yeah, the clinicians stay with the families a very long time and build a close relationship. We good? I have no idea what time it is. Sorry. Thank you.
Okay, our next speaker is Nicole Knighty from the University of Iowa, so my graduate student who hopefully will be graduating this month. And she's going to be talking about mental health disorders and opioid prescription patterns.
There it is. Okay, thank you very much, Kelly. Today I'm really excited to share with you some of the research that came out of my dissertation that was focused on perinatal mental health. One of my research aims was looking at how having a mental health condition during the perinatal time period influenced the risk of using prescription opioids in the first 90 days postpartum. Okay, and so just a little bit of background about what we know about opioids in women. And so older studies have shown us that opioid-related deaths are increasing. So in between 1999 and 2010, we found that those deaths were increasing 5-fold. And from studies looking at individuals who have opioid misuse or abuse disorders, what they've been finding is that individuals' initial exposure to opioids occurs during clinical care to treat pain. And something else that we know is that in the United States, the average birth rate hovers around 4 million births. And it's pretty common for women to be given prescription opioids to manage pain related to childbirth, specifically if you have a cesarean. And then something else that we've recently found in a study is that 1 in 300 women who gave birth via cesarean go on to become persistent opioid users. So this was a study that was done in Bateman about a year ago. And so 1 in 300 doesn't sound like a lot, but when you think about 4 million births per year, 1 in 300 represents a lot of women that will go on to become persistent users. And so despite being a population of women that have a high likelihood of exposure to prescription opioids, we really don't know a lot about what increases their risk of using opioids and how effective they are for managing pain. And so we consider prescription opioid use among postpartum women not to be well characterized in literature to date. And I became interested in this research question coming from a mental health lens. So as many of us in the room know, that depression is the #1 medical complication related to pregnancy and childbirth in the United States. Then in separate studies, we know that having a mental health condition greatly increases your risk of having a substance use or misuse disorder, such as opioid misuse. However, there hasn't really been studies looking at how having a perinatal mental health condition influences your risk of using opioid prescriptions in the postpartum period. Most studies are focused on opioid use during pregnancy, and their outcomes are mainly focused on birth outcomes for the child, not necessarily things going on with mom. So the purpose of my research study was to evaluate how having a mental health condition during the perinatal time period influenced opioid use in the first 90 days postpartum. And so for my study design, I used a retrospective cohort study utilizing private insurance claims data. In my data set, I had around 25,000 women who gave birth in the state of Iowa between the years 2005 through 2016. Women were included in my study if they had continuous insurance coverage, meaning that they didn't fall in and out of enrollment, for at least 1 year prior to pregnancy through 90 days postpartum. If there were women who had a diagnosis code or a procedural code that indicated that they had 2 different types of deliveries, so if it said that they had a C-section and a vaginal birth and it wasn't explained by having multiples, they were excluded from our study. We also excluded women who had a history of substance abuse disorders, including alcohol use, as well as schizophrenia. The reason why we excluded these women is because of the rarity in this data set. So we didn't really have the power to assess how these conditions were related to opioid use. And we also limited our data set to women who are at least age 18 at the time of delivery. And so the first thing I was interested in is how having a mental health condition during the perinatal period influenced the odds of using prescription opioids. So I made this variable that I call the composite mental health variable. So if a woman had depression, anxiety, or bipolar during the perinatal period, I considered her to have a perinatal mental health condition. And then for my primary outcome, I was looking at opioid prescription fills. So my study didn't really look at anything that happened in the hospital, so it doesn't account for any of the opioids that a woman would have been given shortly after childbirth while they were an inpatient. So it's just looking at things that they filled from the pharmacy after they were discharged from the hospital. And so I looked out for the first 90 days postpartum, and first I looked to see if they had at least 1 opioid prescription fill. And then next, I looked at if they had at least 2 fills. And the reason why we did this is commonly when women are discharged from the hospital, you're given a whole pile of prescriptions, and I don't know about you guys, but there's a lot of prescriptions that I filled that I never used, and so they just kind of sat on your counter for a long time. So to be sure that women are using the opioids or to feel a little bit more confident that they were, we also looked to see if they had at least 2 opioid prescription fills in the first 90 days postpartum. And so what we first did is we compared women who filled opioids to women who did not using chi-square tests just to see if there's anything significantly different about them. And then next, to assess the odds of opioid fills by having a perinatal mental health condition, I used various logistic regression models. And so I adjusted for a lot of things. So I adjusted for maternal age at the timing of delivery, their delivery type, so cesarean versus vaginal. And this is important again because the standard of care is a little bit different depending on how you deliver a baby. So it's really common for women who have a cesarean to be sent home with a prescription for an opioid, and that's not necessarily the standard of care for women who have a vaginal birth. And so if you look at the literature, there's about a 7-fold variation between states about related to what types of prescriptions are given to to women with vaginal births related to pain. And then we also looked at an interaction between the type of delivery with having a mental health condition, as well as other conditions we thought were important predictors of opioid use. So if the mom had migraines, fibromyalgia, fatigue, pain conditions, if she had a higher order laceration, so that would be considered a degree 3 or 4, bilateral tubal litigation at the timing of childbirth, her health insurance plan type, and the year that she delivered. And so the first thing I did is I wanted to see what percentage of women in our cohort were filling opioids. And so around almost 39% of our women had at least one opioid prescription fill. And then almost 6% filled at least 2. And then because we know that the standard of care is different depending on how you deliver a baby, vaginal or cesarean, we looked to see, and we weren't surprised, that women who had a cesarean delivery were more likely to fill at least one opioid fill as well as 2 fills. Next, my main question was what the effect of having a mental health condition during the perinatal time period has on the odds of filling at least one opioid fill, adjusted for all of those things that I just covered in the previous slides. And what we found is that women who have a mental health condition have an increased odds by 46% of filling at least one opioid fill in the first 90 days postpartum compared to women who did not have a mental health condition. And then the interaction of having a mental health condition and delivery type was also significant, and I'll talk a little bit more about this in a few slides. Next, I did this same analysis, but now my outcome was having at least 2 opioid fills in the first 90 days postpartum. And again, we found, but even more dramatic, is that women who had a mental health condition had an increase in odds by 172% of filling at least 2 opioid fills in the first 90 days postpartum, compared to women who didn't have a mental health condition that was diagnosed. And again, the interaction between a mental health condition with delivery type was significant. And so we wanted to understand how this interaction between your delivery type, so if it was a cesarean or vaginal birth, interacted with if you had a vaginal birth. If you filled opioids. And so among women who gave birth via cesarean, who had a mental health condition, the odds of them filling at least one opioid fill was increased by 16% compared to women with a cesarean with no mental health, and that wasn't significant. However, it was significant for women who delivered vaginally, so they had an increase in odds by 46%. And then when we looked at having the odds of having at least 2 opioid fills, mental health was a predictor of filling opioids for both delivery types. And so for women who gave birth via cesarean, they had an increase in odds by 68%, whereas women who gave birth but they had a vaginal birth, they had an increase in their odds by 172%. And so in conclusion, we found that mental health conditions are important risk factors for opioid use, specifically among women who deliver vaginally. We find that these findings are really significant because we all know, again, mental health is a really common thing during the perinatal period, and we also know that it's a risk factor for substance misuse and abuse disorder, so it's something that we need to start paying attention to. And then also, there's been a few studies that have found that women in the postpartum period are prescribed many more opioids than they actually need. And so a qualitative study had found that women have an average of 15 pills left over that they didn't use in the postpartum period. And these pills are what can go on to be misused or abused by the woman herself or by somebody else. And so we feel that our study had several strengths. So we used a large population-based sample of privately insured women from the state of Iowa. Using this type of study design, it reduces the threat of recall bias. And what that means is instead of interviewing women to remember when they filled their prescriptions, when they had depression or bipolar or anxiety, that we can just look at the medical records and find that information. We also feel this is a novel contribution to science because we haven't really been able to identify studies that were designed specifically to look at perinatal mental health conditions as an exposure to opioid use. Some studies will adjust for these things, but they haven't directly assessed this relationship as far as we know. There's a lot more research that needs to be done, and so as we looked at the results from this study, we developed a lot more questions than we had answers, but we also had limitations too. So it's important to note that insurance claims data is not made for research purposes, it's made for billing. So some of you may have wondered why I didn't control for race or ethnicity or language, things that we commonly control for, and that type of data isn't available in our insurance claims data set, so we weren't able to look at that. Next, we're not able to examine the severity of a mental health condition. So I know if a woman was diagnosed, but I don't know how severe that condition was, and so we can't assess if that's going to influence opioid use in those first 90 days. And then finally, we're only looking at prescription opioid use, and we know that individuals could have leftover opioids in their home that they're using, so we're not capturing the true amount of opioids that they're using, or they could be using opioids off the street. And then finally, as many of us know, that mental health conditions are underdiagnosed and underreported, and so there could be a lot of women in our data set that we weren't able to identify as having a mental health condition. And so some future directions that I would like to do with this type of research is to identify if this increased use is patient or provider driven. And so, so some of the pain literature, if you look at it, women who have, well, when you have pain, it affects physical pain and emotional pain affects the same area of your brain. And when you use opioids to treat your physical pain, those receptors are also treating your emotional pain. And so potentially if a woman hasn't ever been treated for her mental health condition before, and now she has an opioid related to her physical pain from delivery, she might feel better than she has in a long time. And another piece of it is in some of the pain literature, women who have mental health conditions may feel pain at a greater severity than individuals without. And so on a pain rating scale, somebody with a mental health condition might rate their pain as an 8, where somebody without might rate it as like a 6. And so that's what we consider like patient-driven use of the opioids. We were not really able to tell who's prescribing the opioid. So I'm not sure if it's the OB that's prescribing the opioid that delivered the baby, or if the mom is going to their family practice doctor and getting the additional opioid prescriptions. And I think it's important to identify who's driving these prescriptions for interventions and education at the provider level. And then another piece of this is education for patients and providers. So I cannot find any research studies that shows me how OBs are educated related to prescribing opioids. I did find a study looking at surgical residents, and the surgical residents reported that only 8% of them received formal pain management during medical school. Only 6% of them had formal education related to opioid prescribing, and these are residents that were in school just a couple of years ago, so it wasn't like they were interviewed before the opioid crisis, so you would expect them to have a little bit more information about opioids. And then finally, when these same residents were interviewed, they asked about what type of education that they're giving their patients. 95% of them reported they'll tell their patients they may become constipated, but only 6% of them discuss the threat of opioid overdose. So there's a lot of work that needs to be done for both patients as well as providers. And so we know that perinatal mental health conditions has this multi-generational effect. It can affect the moms, it can affect her baby, her family, the community as a whole. And so this is research that I think we need to continue to look at and better understand so we can improve maternal and child health. And with that, I'll take any questions. That's my 4-year-old when I take him to work.
We have our last visit report of break. Nicole, if you're available on the break. Do you want to have one question? Awesome. He's going to be our take the break. All right, thank you so much.
Okay, let's see. Oh.
And here's in the folder. Yep.
Okay. So I know I'm what's between you and the break, and I will do my best to shorten things a little to go along. I also have the motivation that I have 2 3-year-olds in the next room who are still working on potty training, and we did not bring extra underwear. So I have a few things to work with. And actually that works out well, because part of what mindfulness is about is rolling with what comes and knowing that things will probably change from what you expect. So here we are. Let's see. So I was going to give a little background on my interests. I think I'll kind of skip over some of that, but I wanted to say also that for any of you, since I will be kind of hurrying things along a little bit, if you have questions or are interested in hearing more, I know the slides will be available, but do feel free to reach out to me. I'm happy to send more information or talk with you. But suffice it to say that I have had a long-standing interest in depression. I've been personally touched by depression in multiple ways, and I'm especially interested in understanding sort of what are at the roots of this, what drives this kind of intergenerational cycle, and how could we interrupt that. So we know that there are a lot of different forces that can be leading to depression during the perinatal period, and there are some identified risk factors, things that you're probably aware of, like age, younger mothers, mothers from lower income backgrounds, low partner support, prior mental health problems, all of these things feed into risk. And that's important to know, but I wanted to know more about what is it that's in between here. So what is it that we could actually do something about that might be part of the mechanism or explanatory kind of process. So this will not be a surprise to most of you that you could say a lot of these risk factors, in the end, part of what is happening with them is they're increasing stress, right, during pregnancy and postpartum. So, one thing that I've focused on is, okay, there's stress that is perceived in different ways by the mind, but it also is working on physiological systems in the body that in turn are influencing the way that we feel. So there are multiple aspects of the stress response that can be activated by these different kinds of stressors. I've focused especially on the hypothalamic pituitary adrenal axis, and I promise that's the sort of biggest acronym type word that I'll be using. But it is basically how the brain communicates with the adrenal glands to pump out the hormone cortisol, which is useful for responding to short-term stressors, but in the long term has been associated with lots of physical and mental health difficulties, including depression. So that could be part of this process. We also know that there's a lot of research showing that high cortisol levels both tend to contribute to escalating depression during the perinatal period and may be an outcome down the road that mothers who are depressed go on to show higher cortisol in interactions with their child, and that may be part of what's making it hard for them to parent effectively and maybe giving rise to risk in the next generation. Then during the postpartum period, some of these other risks can be compounded, again, with low social support, or just the stresses of adjusting to the parenting role and to trying to respond to this baby's distress and all of the things that they need if you're already dealing with stress in your life. So we know that various stress reduction types of strategies can be helpful, and I think a lot of the programs that people have spoken about, coming from my lens, in part they're working because they help with coping with stress. One of the approaches that we already heard about yesterday is mindfulness, and I could say more about mindfulness, but you got sort of the basic definition. I would say it's really about being open to what comes in unfolding experience, rather than kind of being lost in thinking about how it should be, struggling against the reality of it, that there are various ways we try to escape, especially from painful experience. And so to the extent that we can learn how to ride out these waves of stresses and also joys that may come at various times, but especially during this perinatal period, the more we can take care of ourselves. And I think it can be especially helpful in this perinatal context where, again, there are concerns about medications to work with mental health problems. And also which has been brought up before in this symposium, the stigma potentially of seeking out mental health services or psychotherapy whether that's accessible or just something that there are other sorts of barriers about wanting to identify in that way or use those kinds of services. And so mindfulness-based interventions tend to escape some of those difficulties, and so I think could be more accessible and acceptable to women during this time. So we know a little bit on the research, and I won't spend a lot of time here, but that mindfulness during pregnancy has been associated with better mental health, lower anxiety and depression, also some better physical kind of health outcomes, so lower gestational weight gain for the mother, and at the same time higher gestational weight gain for the infant. So even these sorts of birth outcomes seem to be improved. And some of the findings that we've been doing with our pilot research is supporting benefits for mental health in the mother, as well as the father or other partner who's involved in mindfulness work, and also a better sense of bonding with this baby even before they're born. And then postnatally, there's evidence also for better maternal cortisol recovery during stressful interactions with her baby, as well as lower infant cortisol during these interactions. So it seems to be showing up in these effects kind of under the skin, both in the mother and the baby, that they're able to move through the challenges that come with these early years less stressed. And then I'll throw up, I won't go into this, but some other research that I've done involving looking at the maternal brain and how that responds to her infant. We found differences related to maternal depression that seem to be counteracted by mindfulness. And this was just looking at differences in mother's brain response to her baby's emotions based on individual differences in what we call dispositional mindfulness, so just your tendency to be more present and open to experience, even if you haven't done mindfulness intervention or training, and that it seemed to shift. In particular, these blobs up here are showing parts of the brain that were more responsive to kind of positive or rewarding interactions with their baby, as opposed to moments of distress. And so we know that in general, part of what fuels depression is this kind of bias toward the negative, which we all have to some extent, but is exacerbated there. And so it looks like there's this way in which mindfulness may help mothers to kind of reverse that and be able to focus more on the joyful or the positive with their baby, and that may be helping both of them. So I was really heartened by this, but also it's a correlational kind of finding. We're not going in and doing anything to change maternal mindfulness, so we can't really say that mindfulness would cause some sort of beneficial effect either on her brain response or her hormonal response during these times. So I really wanted to look in a more experimental sort of causal way if increasing maternal mindfulness during pregnancy could help with these downstream outcomes. So this is a study that we did get funding for, actually, and we're just gearing up to get going. So that's what I was really excited to talk about today. And again, invite you to reach out to me. Part of what I'm glad to do here is just to bring more awareness to those of you who are working with pregnant women in the community, to know that this is something that we're starting up and would be an opportunity, and we're really looking to start recruiting for this study. So basically, the aims of this research are to look at how participation in a prenatal mindfulness-based childbirth education class might impact both maternal mental health, aspects of her ability to be present with in a mindful way with her baby, and also her sense of bonding with this baby. So this first part of it is just looking at differences between mothers who do the mindfulness-based childbirth class during pregnancy and those who take some other form of childbirth preparation. So it could be that there are similar benefits. It could be that there are some special ones that come with mindfulness. But comparing these two groups on sort of maternal self-reported mindfulness and bonding, as well as depression and anxiety. The second part is to then extend that to, is it impacting the way that her brain is responding to her baby? And that these may or may not be lining up together. So it could be that her subjective sense of bonding with her baby is differing and that we're not seeing that showing up in the brain, or vice versa. Sometimes looking at the brain or other biological systems can give us kind of an earlier sense of processes that are going to continue unfolding. So, for example, with the depressed mothers, we found that there were differences in brain response that weren't necessarily matching up with her perception of how she was with her baby. And so it might be an additional kind of screening tool for understanding where are there things that are going wrong here, and what might we want to be able to do to reverse that before the problems become entrenched. So I do have some acronyms up here for brain areas, but basically that there are parts of the brain we would expect to be enhanced by mindfulness training that have to do with regulating your attention and also your sense of being open to reward and protection against depression. And then the last part is looking at what are the moderating factors that might make this kind of intervention more or less effective for some moms. So wondering, does, certain characteristics of her risk status going in, like being a single parent, having a history of birth complications, or just greater levels of distress coming into pregnancy, is this kind of prenatal mindfulness intervention more or less helpful for women with these different characteristics? So we're looking to recruit 60 expectant women total and partners, or these could either be romantic partners, it could be fathers, or just some other support person. So we don't want to limit it necessarily to mothers who are partnered or in some sort of a stable family situation. But that there should be someone who is participating with her who can be part of her ongoing support network when she goes into the postpartum. And one piece of this particular intervention is looking at how that can be increased. And I'm seeing that I'm actually already behind where I hope to be on the time. So I will move it along. And just to note that they are paid fairly well for their participation, and we hope that that will help with being interested in being involved in this study, being engaged, and being able to continue across the study. They also get this whole mindfulness class for free. So we would be starting around 28 weeks of pregnancy to give them a chance to participate in one of these classes, either the mindfulness-based childbirth and parenting program, which is a 9-week class, or an alternative childbirth class of their choice that we would pay for. And then they will be followed up at 3 months postnatal. So these, at all times, they'll be self-reporting their depression, mindfulness, bonding. And then at the final session, they'll be doing a video recording with their baby, and then they'll be seeing these video clips and looking at brain response to that. So mindfulness-based childbirth and parenting, I have some information about this, and we'll just say it was developed by a midwife who also was a mindfulness instructor and really interested in how I can bring, sort of the health benefits and insights from mindfulness work to this special time. And so I'll say a little bit about the different sections of the course. The first part is really borrowing a lot from mindfulness-based stress reduction and sort of a grounding in what is mindfulness, how can it be applied to the challenges of childbirth and parenting. Women learn certain formal meditation kind of practices, like the body scan, different kinds of sitting practices that involve just greater awareness of and stabilizing attention to both sensations in the body and starting to expand to things that are going on in the mind. And so this becomes more of a tool for working with mental distress, as well as informal practices. So one of the misconceptions I think about mindfulness is that it's all about, sitting off on a cushion somewhere, meditating. And that is one way of trying to practice these skills. But what we're more interested in is how can you bring this to your daily life and the things that come up in your life. And so part of it is also just looking for ways in your daily routine to bring more awareness, to kind of pull out of autopilot and be able to work with experience as it's coming. The second part of the class is really more about the childbirth itself and preparing for the both physical pain and perhaps fears or kind of emotional turmoil of childbirth. So there's a certain amount of just birth education, but from a mindfulness kind of lens. Also being able to help inform women about their choices and reflect on their intentions for the childbirth process, given the kinds of facilities and possibilities in their area. And not developing a birthing plan, because that assumes that you can plan things out in advance and know exactly what's going to happen and control it, but to have intentions for how you want to meet what will come. And then there are practices specifically for working with physical pain and using mindfulness to work with that. And then the last part of the class is really about preparing to become a parent and what are the things that will come with that. So some of it is stuff that you might get at standard classes about newborn needs and sort of anticipating what their cycles are going to be, about breastfeeding, but again, how you can bring mindfulness principles to these situations. There's also a certain amount of reflection on your own parenting experiences and sort of how that shaped you and what you want to bring forward into your parenting relationship with a partner. And then again, building that support network, not only with a partner, but with this larger community of the group in the class and others in your social environment for that postpartum time. And part of it is education about recognizing postpartum depression and what are things that you can do or need to access to take care of yourself if that is part of your life. So we've been piloting this already in the community here, and we're going to be starting this study of it, but already just looking at self-report measures for the people who have undergone some of these classes, we are seeing, thankfully, increases in mindfulness, increases in a sense of bonding with your baby even before they're born, as well as decreases in depression. And this was, again, for both the pregnant women and their partners across the course of this class. And then we did do some course satisfaction sort of questions, and out on a scale from 1 to 5, the averages were pretty close. It was like 4.6 and 4.7 for how satisfied are you with this class and how much would you recommend it to someone else. So even though it's a pretty big time commitment, and in these early classes women have also had to pay for it, they have come away really feeling like this was valuable for me. So this is my little pitch for some of the things that we're going to be using for recruitment. But already, if you have in mind either women that you work with or others who might be interested in partnering with us, there are multiple ways that women can get involved and get sort of pre-screening to see if they're eligible for the study. So ultimately, this is the hope, is to have these cascading effects through this early intervention on the way that she's responding in all these ways, and that will really give rise to this more healthy cascade of intergenerational mental health. And that's the promise that I see with this work, and I'm glad to be part of. So thank you for your patience and giving me the chance to talk about this today.
So we are missing one advisory board member. She'll be joining us here in a minute. Is this working? People hear me? Okay. Okay, so we're going to start. Today's event, we're going to build upon the event that we did yesterday. Now we have a new panel of advisory board members that are sitting up here. And we're going to ask them a series of questions really focused around why they joined the advisory board or coalition and what their interests are and what they think can be gained from this opportunity. So I'm going to start off just asking everybody to introduce themselves, and then I'll start with the first question.
Hi, everybody. My name is Kate Ross, and I'm on the IDEA Coalition Advisory Board. I'm a soon-to-be graduating with my master's in social work a week from today.
Hi, my name is
My name is Megan Kirkpatrick, and I am also on the IDEA Coalition Advisory Board, and you might have noticed I'm working as a project manager here today. So, involved on a couple levels.
My name is Sarah Connell, and I am on the Community Advisory Board for the Iowa Perinatal Health Research Consortium. I just have to think of the letters when I say that. But I am a mom, and my interest stems from delivering my son at 25 weeks. And so I'm interested in all things prematurity as well as downstream from prematurity, and particularly mom-to-mom outreach support to moms both on hospital bed rest as well as through their NICU stay and beyond.
Hi, my name is Lori Short. I work at the University Steve Family Children's Hospital, and my first gig there for the first 15 years was in neonatology. And now I direct a statewide preschool vision screening program, and I'm tired of talking about vision screening. I've been doing that for 20 years. So I kind of wanted to, I just finished a board, national board with that, so I wanted to volunteer doing something else, and I decided I wanted to go back to my roots at the Children's Hospital and get back into it. And I think that I maybe offer a different perspective. I too am a mom, but I had one of those, I had a flawless pregnancy and delivery and afterwards, but there was one day I was sitting at the gas station too, in 2 weeks being a mom saying, how are we ever gonna do this? I think I can offer a little bit there too.
Great, thank you. So the first question, which I think we had a little bit of answer on, but I'm still going to have us go through, is what led you to join the advisory board or coalition activities?
Similarly to what a lot of women have shared the past couple of days, and I'm really so thankful that everybody's being so open. I had experience myself with, I became a mother almost 10 years ago in June, and I had very severe postpartum anxiety, and I did not, even though I asked for treatment where I was supposed to ask at my doctor's office, I was not validated and just sort of dismissed in that, and so then I had a long-term problems with my mental health for years after that I've fortunately been able to get treatment for now, but it's one of those things, like everybody's been said, like, where was that help that I should have had 10 years ago? And I would love to be kind of part of the solution now, so that's why I was interested in the board.
Hi, so why was I interested in the board? Well, Karen was a good friend of mine and told me I should do it. But in a more honest way, I have struggled with depression and anxiety throughout adulthood, and I moved to Champaign about, I guess, 5 weeks before I had my first child, and so not having family nearby, not having friends, not having an established provider, it was pretty jarring when I had my first child, and I realized quite quickly that something wasn't going quite right, and so I reached out to the midwives, and I actually have the other side of the story where I did get listened to, and they got me in. I was already on medication, but they got me in with counseling right away, and was able to get a lot of the support I needed. And so, but I have struggled with mental health throughout my life, and so I really think, especially at that period when you just become a mom and you have this newborn to take care of, and it's such a vulnerable time for both the mom and the baby. And so if we can wrap around moms at that time, that really sets them up for success as mothers, but it also sets their children up for a lifetime of success.
I too have struggled with depression and anxiety for my adulthood, and so during my pregnancy I was on the radar as someone who was at risk for postpartum issues, and then having lived through HELP syndrome and an emergency C-section and a 4.5-month NICU stay, pretty much all of my issues were heightened. With depression and anxiety and PTSD. And I think one thing people don't talk about is the grieving process. So I was grieving the loss of a normal pregnancy. I didn't make it to the 3rd trimester. I had 1 ultrasound during my pregnancy. Grieving that attachment, initial attachment with your baby. My son was a month old before I got to hold him. They let me hold him the day before he had heart surgery when he was about 2 pounds. He'd almost doubled in birth weight. He was teeny tiny. He was 1 pound 5 ounces when he was born. So all of that to say, we had a great support system with family and friends and our church family, and they were great, but they didn't get it. They weren't walking in my shoes, so they provided a lot of sympathy, but that empathy piece was missing. And so since that time, my son is now 8, and he's a little wonderful, energetic, bright boy who gives me joy every day. But in those past 8 years, kind of my passion has become supporting other moms who have gone through the NICU period. And so I've done this in a number of different ways. I've been on the Family Advisory Council for the Stead Family Children's Hospital for 8 years. I am an admin for a Facebook group that's NICU Families of Eastern Iowa, and we have over 1,500 members everywhere, all stages from moms who are on hospital bed rest anticipating a NICU stay, all the way through to, one of my favorite stories is somebody posting about their NICU triplets graduating from high school. So it really spans the spectrum of prematurity, because we know that prematurity doesn't end when you leave the NICU. I also do outreach with moms on hospital bed rest. So we have an organization where we provide mom-to-mom support, and all of our volunteers have either been on hospital bed rest, had pregnancy complications, had a NICU stay, or more likely a combination of those things. And so we reach out as that person who gets it, and who can identify with, if not the exact situation a mom is going through, elements of it, more so than, say, her support system could offer her. So when this opportunity came up, and actually I received an email from one of the research nurses in the NICU, and she knows what I've been up to since our stay, and we participated in research studies when we were in the NICU, but she brought it to my attention, and I thought, this is right up my alley. This goes right along with a lot of my passions and interests, and I hope it opens new doors for providing support in the perinatal period for moms as well as their children.
So all I can say is you've come a long way, baby. Because I came into, my experience with this came before all of those support systems happened. I was working in the NICU from 1989 until 2002, and the way it worked, I felt a little bit like the Peanuts gang, and I was Lucy. And the mom who was either expecting a high-risk pregnancy or was going through in vitro would sit in my office waiting for a half hour for the doctor to come and talk to them, and I got to know these women really well and what they were going through and how they were dealing with it. So again, that's my angle on it. I think it's maybe the opposite of what you were experiencing personally. I saw it from a different perspective. I was outside of the circle looking in. So that's what brought me to it, thinking I can provide a different perspective.
Good morning. I'm Imani Anwishe Mashele. I'm a family physician. I'm sorry I was a little bit delayed. I'm actually on call, so I had to answer that call. My interest in joining the IDEA Coalition sprung from some of my experiences, both as a patient, suffering from a second trimester loss, and some of the challenges emotionally that occurred as a consequence of that. Prior to our firstborn, and then he had an extended NICU stay, and so that sort of compounded some of the challenges. So as a patient, it really highlighted for me those experiences, the importance of having support, and I was able to navigate the system very well, having been a physician at that point for both of those experiences. But my patients, many of whom initially, I guess I'll back up. I've been here for about 3.5 years working at Carl in the family medicine department, but prior to that I worked in a community health center in St. Louis. In both settings, we interacted with moms, like most of the moms in this room, who felt that they often would suffer in silence. And so, you would see people here and there, and I would feel limited in my ability to impact, limited in what I can do in the exam room, but also limited, especially since moving here, and really understanding what resources were available to patients in general, but especially to patients who had who come from marginalized settings, so patients who may have limitations in transportation, limitations in logistical support. And so my main interest came from just the idea, the promise that maybe by doing and contributing to this board, we might be able to impact on a larger scale most of these moms in need. Also, have a background in public health, as in I have a master's in public health, but since graduate school, I didn't really find the time with primary care to actually use those skills. And so it appealed to me in the sense that, okay, well, maybe now we can start to kind of dust off some of those skills and utilize them in that way. So I think that's the answer to the first question. Is okay. All right.
Great, thank you. So the next question is, what were your expectations when you joined, or did you have any expectations when you joined?
I had kind of an advantage because I'd already been working with Karen as a research assistant, and so I just knew that she was doing this coalition, and I knew that it was about research, and I think because I was a grad student, I kind of already was privileged to already know a lot of that verbiage and have already been reading, so my expectation was to, participate in the research, and I was really excited to do that.
My expectation was that I would have an intellectual and social outlet, because my full-time job is as a stay-at-home mom. So I wanted to be able to think again and use my brain on something that didn't involve my family. In terms of the expectations, I joined the board. I went to the first board meeting. Amane, I think you were there too. And coming from the patient partner perspective, we didn't know what to expect. And even after going to the first meeting, we still had no idea what to expect. It took us like 2 or 3 meetings before we got up our courage to tell Karen that we have no idea what we're doing there, or why we're there, or like we got selected, we don't know why, we don't know what we're supposed to offer you. Research was, I don't come from a science background, I come from working in nonprofit and English and grant writing. So this was all super, super foreign. And I think that was one of the biggest things for the board members. We all knew that we shared a passion, but we had no idea what we were supposed to be providing to the board. And most of us would say things like, well, I don't really have anything to offer. I don't know anything about research. I don't know anything about this. So that's been a big learning process on our board, is learning what we do have to offer, and why our perspective and why our thoughts and ideas are so valuable as patients and as providers, and also learning how do we communicate, because someone said something about it there being 2 different languages, the researcher language and then what the rest of us speak, and even though Karen had been my friend for years, I still didn't know her as a researcher and how to interact with her in that arena. So there's been a tremendous amount of learning on both sides about how to come together and communicate. Sorry, that went off.
So we are still very new. So I think all of our expectations are probably still unfolding. I kind of jumped in with both feet, coming from the experience I had sitting on the Family Advisory Council for the Children's Hospital, where we talk about patient and family-centered care all the time. And this just seemed like an opportunity to continue to be that voice of the patient, of the child, to continue to be heard. And I am a science girl. I'm an optometrist by training, but I've worked in research for about the last 14 years. So to kind of bridge that gap and learn more about the research on this side of things, it just seems to me an opportunity to become better informed as well as to inform.
Okay, I didn't have a whole lot of expectations. I really kind of wanted to see where the field had gone since I had been in it. And I think I'm still kind of discovering what my expectations are. I want to contribute to a greater good, of course. And the subject matter was something that I had a very deep passion about early on, and I'm kind of finding it again.
I think I expected to learn more about how community engagement research works. My limited experience with kind of qualitative research in the past had been definitely separated from the community. And so I think my expectation was and still is to learn how to really involve the community that we're attempting to serve in the sense that addressing questions that are pertinent and relevant to both researchers and community.
Thanks. I think Karen and I both addressed this a little bit in our talks, but is there anything that anyone would like to add about what kind of activities you've been involved in as a board?
Well, I just joined our board 2 months ago, so I'm pretty new. So far what we've been doing, because we've been approaching this month of May with all these events, it's been event planning and just kind of discussing what we want these, the expo and then the symposium to look like, and then also participating in that interview training that I think Karen mentioned. So that'll be kind of the exciting new thing on the horizon, to start interviewing patients.
I would just add that I think one of the most awesome parts of being on the board is the degree to which I feel like our voices are actually heard and considered. There's been times where Karen or some of the other leads have brought in like, hey, this is this amazing intervention, I think we should do this. And our board all kind of sat there and went, you know, that is not something we're interested in. We don't think that's a good idea at all. And then that was it. It was off the table. So, I think in the beginning we were really kind of like, well, are they really going to listen to us? Like, we're patients and we don't have a PhD in anything. But so that's what I would say. Like, there's lots of activities we've done, but primarily we're used as thought partners. And that feels really great.
What challenges have you faced as a board? What are some of the challenges or difficulties of being a partner or stakeholder partner involved in research? No?
I guess
we're not there yet. We're not there yet.
For me, right. I would say that is my challenge for me personally, is being new. Like Karen said, it's hard to sit at a table with 14 people and you just got there and you don't really know anybody. Like, it's hard to know when to speak up and to have the confidence to do that. And so that, and then also just from a personal perspective, like I said, I had my own experience with postpartum anxiety. It was 10 years ago. So I thought, okay, that was 10 years ago. I've worked so hard, I'm past it. Here I am in grad school so that I can help families who are experiencing this. So it was interesting that I had some like emotions come up when we would start to talk about these things, because it is like, wow, just, it's like the mixture of excitement but then like grief of like, why wasn't this there? Like, the solution seems so easy sometimes. It's like, why weren't they doing this? Why is all of this suffering happening? So it's just like kind of frustration mixed with excitement that we are doing it. So that's been my experience of a challenge.
I mentioned what I think our biggest challenge has been, which is around communication. I think, and it's communication slash patient education around research. And so we've talked, and we didn't, I mean, so I guess the part from coming from the other perspective, Karen hadn't led a group of patient researchers before. So she doesn't have she doesn't have experience with how do you help everyone get on the same page, and how do you, so it took us, I think the primary thing has been just helping us all get on the same page where we understand what it is we're trying to do. And then we've had a lot of times where we've gotten really excited, like either we'll brainstorm and we'll come up with a ton of ideas, and then it's really hard, like how do you get 14 people to take those 20 ideas you made up with and turn it into an actual research question? That's been challenging. And then also the patient, like the same thing, we come up with a whole bunch of ideas, and then either David and Karen on the research side say, well, actually, we don't have any data about that, so we cannot study that. And then I come from a fundraising background, so I'll raise my hand and say, yeah, that's great, but that's not what PCORI funds. That's not in their interests. It's not a comparative effectiveness research question. So it's just navigating, but I think it's a challenge, but I also think it's really beneficial. I think it's really amazing to have researchers sitting side by side with patients, thinking through what should we research, what will make a difference.
Yeah, I agree. I think one of the biggest challenges then and even now is really kind of understanding what comparative effectiveness research means. I know that it was nice, in the beginning when we would go through kind of the PQADs, like the population, the intervention, comparative and outcome, and that was helpful in kind of helping to focus our questions. But even then, as you say, if there's no data to compare to, then it makes it challenging, because we all have really, really, really good ideas. And so being able to fit it in a framework that fits both funding and the research model was a challenge. It felt very messy at times, I think, but it felt good, because it felt like this is real work. This is not something that's stuck up in some tower somewhere, but it's actually something that is hopefully going to be applicable and doable. I think one of the challenges, as I see it, I don't know if this is necessarily a board-wide challenge as such, but just increasing the diversity on our advisory board. So people who are coming directly from the communities that are served, who don't have, who have maybe just a high school education, or who have strengths in other ways that we may not have, who have challenges in other ways that we, and I say we because I think that a majority of our board actually have a college education, and so I think that that is a challenge, because one of our intents is to reach more marginalized population, and we want to make sure that their voice is being heard and we're not speaking for them. So I think we're working on that gradually as a board. Other challenges, no, I think actually kind of spoke to that. The idea that we all have different experiences is actually a strength. I find it's just really refreshing to get out of kind of like a medicine bubble, because even though I have the patient role and the stakeholder researcher role, I don't really feel like I fit into a typical patient, because I can see both sides of it, and so it's very, very refreshing. So even though it is a challenge, on the other side, it's a strength, because we have a diversity of experiences that we can bring to the table.
Great. Can you talk a little bit about how your board has changed or evolved over time? And I think this probably goes more towards Idea Coalition, because as we've said, we're new, so we haven't changed too much yet.
Okay, I would say we definitely have gained certainly an understanding and a confidence in what we're doing. I feel like the board members who've been on it for a while have a clear idea of what we're trying to achieve, what is patient-centered research and what is comparative effectiveness research. We're starting to understand these things, and I would say we've also developed pretty strong relationships among us, because we're coming from all these different perspectives, but we get to talk in a very open and real way at the board meetings, that is also very it's very refreshing to have a professional setting where you can also share things from your personal life.
I agree.
What have you gained or learned from being on the board so far?
Something I've gained, I would say, is just like I said in my first answer, just kind of feeling like I'm part of the solution. So it's kind of like a healing experience for somebody who has had this problem and knows what it feels like personally, has seen it in friends and things like that, to really be sitting around the table and just to sit back for a moment and think, wow, like I'm at the table, the proverbial table, I'm in the room, making this research happen and having my voice be heard. So that's been something, and just I've already learned a lot from my other board members just in the past 2 months too, all their knowledge.
As a stay-at-home mom, I think for me, one of the biggest things I've gained is the opportunity to put back on the professional hat and have articulated thoughts. And so the board is very purposeful. There's childcare always provided. We meet on Saturday mornings when both working moms and stay-at-home moms can be present. There's food provided for your kids and for yourself. So it's been really, really wonderful to get to engage intellectually with people from all these different perspectives. And it's been so interesting just to hear about the diversity of experiences that people have with postpartum depression, because I have private insurance, and I had a midwife who really went to bat for me to help get me into care very quickly. And just to find out, for me, it's been very eye-opening to talk to people and hear about just how different it can be than that, and how fewer resources you have if you don't have private insurance.
Even though we're early on, I would say kind of the two things that popped into my mind about what I have gained so far. One would be perspective, and probably just thinking from a more empowered standpoint. Like, I have something to offer. Jacob and my story can help inform future research. Our experiences can, open people to new ideas or to new thought processes. And then I would say the second thing is just an excitement or enthusiasm. I'm excited to be involved, and I'm excited to kind of have the forum to share our story and have my voice be heard.
I think for me, in addition to all of what's already been said, I agree with that. As a physician, I think I was always alerted to the challenges, but I feel that my ability to identify maybe early signs or postpartum depression that was undetected in that first few months, or postpartum depression that has, just started after 6-8 months, just in various periods. I think it's just really made me more sensitive to the experiences of my patients, and because we have many community resources represented on our board, I think I now feel more empowered, or at least more equipped to provide, resources to patients in our community. So I think just from a family physician standpoint, I feel stronger in my ability to take care of patients during this period.
And I'm not sure I'm supposed to answer the question, but I'm going to anyway. So from the researcher standpoint of putting together the Community Advisory Board, and Karen spoke to this a little bit this morning, but as someone who'd become sort of disenchanted with the research I was doing, you get kind of stuck in this rut, and research is supposed to be about passion and love and drive for a subject, but in the end, we're still trying to earn a living and get grants funded and do our jobs. And as someone who kind of got stuck in that role of just doing the work to get the job done, what I really found is that this re-energized my passion for why I got into this in the first place. Hearing people's stories, understanding where they're coming from, being able to incorporate that, being able to think I can actually make an impact, because I think a lot of times when we're doing the research, as Karen mentioned, it gets published, so what? Like, what's going to happen next? And being able to share that story and have that impact has been really important to me. And I think that some student even mentioned here today that this has given her a new perspective and a new energy for doing the research. So I think that's been a really big benefit. Last question is, what is your vision or dream of what this advisory board might be?
I thought it was really cool to hear what the women who spoke about the Rochester, just about how they're kind of like a fixture in their community now. They've been going on for 7 years. That would be really cool. And then just also, I've lived here in Champaign-Urbana for 15 years, and I think if you live in a college town long enough, chances are you might start participating in research. Like, so whether that's getting a form home at your kids and you just, sign the consent form, whatever, yeah. Or like we have the Beckman Center here in town. You're there at like 7 a.m. with wires coming out of your head, so you can get your Amazon gift card. Or I ate avocado for 12 weeks every day, so they could study. So it's just like you feel like a subject. But do you get called when that research comes out? No. You have no idea what happens after you come, you do your thing, you move on. So I just think it's really cool for the university to actually engage community members as part of the research from start to finish, so they don't just continue to feel like subjects, which is great. Like I said, you get your Amazon gift card. It's awesome. But to actually get called, like, hey, here's what this study's about. What do you think we should be studying? Like, I just think that's my dream, is that the Idea Coalition can kind of be that public face of the university and Champaign-Urbana really cooperating together to make some changes.
On a personal level, my goal is to be interviewed on NPR about the work we're doing. If anyone has a connection to an NPR host, I will take their card. That's not really a joke. But as a board, I mean, I would love to see us get funded for a long-term qualitative study, and I'm super interested in finding out because what we're doing right now, we got funding in order to sit down and have us as the patient researchers interview women who've taken the perinatal depression screening and find out about their experiences with it and what information was done, which I think Karen mentioned a little bit about. I'm really interested to see when the people doing the research are the patients themselves, how does that impact the information that you can gather? And are patients more likely to open up to a fellow patient? What kind of a trust is established when it's a mom talking to another mom? So I'm super curious to see what we find out, and just excited to learn. And also, I mean, the ultimate goal would be to have a positive impact in our community on women's access to mental health services.
Again, because we're in the early stages, we don't have necessarily concrete projects that we're working on, but I shared my passion with you about this mom-to-mom outreach, and I would love to see some work done looking at that more peer support role and the impacts that can be made by a lay person on other people with shared similar experiences. And then with my son being a micro-preemie, I'm also interested in longer term outcomes. There's really good support for these kiddos until they're 3. And after that, it's a little bit more hit and miss, and we're not being followed by an intensively trained team who has experience in older micro-preemies. So we're relying on the pediatrician, on whatever resources I, as kind of an information geek can scrounge up like, ooh, maybe we should take him to this clinic because it sounds like they might have some resources that could support him. So just kind of thinking about some of those longer term outcomes in these kiddos and the impact that maternal health and maternal mental health has on some of these longer term outcomes, such as learning challenges or ADHD or anxiety and depression in the children of these moms.
And I'd like to give out a shout out to this conference for putting Sarah and I in a car for 4 hours together, because we mapped out 2 grants already that we have that we want to put in on the peer-to-peer support and the outcomes in older micropreemies. So I think we're on our way.
Good. Well, I felt all kinds of excitement for sure. We are very new. And I think as I think about it in terms of what I hope we accomplish as a board, I hope we help strengthen the infrastructure at our institution and help put new processes in place by identifying different needs. So that's my early hope.
I think for us, I would love to see more outreach to marginalized communities, so maybe focus groups that are embedded in churches, community centers, so that we can get kind of generating, again, research questions that are, or even just general concerns that could turn into research questions that are pertinent to those communities. So that would be a vision of mine.
Great. Well, I'd like to thank again all of the panelists for sharing your experiences and also for getting us to lunch right on time. I mean, that should be an extra standing ovation clap. Thank you.